Bore da, good morning and welcome to today's Digital Health and Care Wales Programme Delivery Committee meeting. In relation to today's proceeding, I'd like to note the following. Committee members, including myself, won't always be looking at the camera. We do have committee papers that we will be referring to during the meeting, and they're usually on a separate device. We're planning to take a 10-minute break after section 4 of the agenda and hoping to conclude today's meeting by 12:50. I don't plan to go around everybody at the start of the meeting to do introductions. So what I would ask colleagues to do is when they speak to an item or ask a question, if they could please introduce themselves then, that would be more efficient. With that said, I'll now move to the main part of the agenda. First item is apologies for absence, for which we've received apologies from Chris Darling, Director of Corporate Affairs and Board Secretary, and Simon Jones, our Chair, who's enjoying himself somewhere in the Caribbean, I think. Declarations of interest, I've received none in advance of the meeting. So if I can ask colleagues to raise anything that they might need to in relation to today's proceeding, to do it now or when the item occurs. Can't see any hands, so move on to the next agenda item, which is the consent agenda. I've received nothing in advance, and we're being asked to approve one item, which is the minutes of the last public meeting and the abridged minutes of the private meeting. Could I just check before we approve those if anybody has any amendments or comments that would wish to record before we approve them? Right, there's no hands up, so we will formally approve the minutes of the last meeting, both the public and the abridged private. The forward work plan is there just purely for us to note. And with that, I'll now move on to the main agenda. First item 3.1 is the action log, and I'm pleased to report that there are currently no outstanding actions on the public action log. So with that, we'll move swiftly on to part 4 of the agenda, the assurance agenda, and I'll now ask Evan Evans to introduce and lead on some of these items. Over to you, Evan, and welcome Lawrence, who's supporting Evan on a couple of these items.
Diolch yn fawr iawn, David. So I'll introduce myself. Evan Evans, I'm the Executive Director of Strategy in Digital Health and Care Wales, responsible for planning and strategy, but also for the programme, for most of the majority of the major programmes portfolio. Colleagues are on the call today that will give updates on various programmes. We go through the main part of the governance and assurance later on today. But first, we have our assurance reports. For viewers who are watching for the first time, each of our designated major programs brings an annual update to this committee for assurance on top of the regular cycle each quarter, and that's a really good opportunity for the program leads to give an update which looks back, typically would look back a year and then look forward a year to give a sort of status update. With 4 on the agenda today, 2 of them are in full flight, as it were. So Lawrence will be presenting on 2 digital medicines programs and picking up a couple of projects also in the medicine space. And then afterwards, we have 2 programs that are in closure phase. So they're moving into closure phase, and we have Alex presenting on those. I think we've got just over an hour for presentation on these. So Chair, I think I'll hand over to Lawrence to go through the 2 digital medicines programs, and then back to you for a discussion, question and answer, and then we'll move on to cancer and to digital maternity, if that sounds like a plan.
Excellent plan, thank you.
So, Border, everyone, can you all see the slides on the screen?
Yes, we can.
Fantastic, great. So, Border, good morning. My name is Lawrence James. I'm Head of Digital Medicines Programs, and the purpose of my presentation today is to provide an update on achievements and progress we've made the past 12 months and since the last presentation, which I presented to the committee. So in terms of key strategic and policy drivers for the digital medicines programme, there were 3 key documents. The first on the screen there is the Pharmacy Delivering a Healthier Wales, which was produced in 2019. There's a statement to implement e-prescribing across NHS Wales by 2025. The second key driver, policy driver and document then was the future of electronic prescribing in Wales, which was published in 2021. Welsh Government commissioned a independent review into e-prescribing capabilities in Wales, which resulted in a number of recommendations, which formed the Digital Medicines Programme, which had a vision to deliver a fully digitised electronic prescribing environment across Wales. And the third key document then is that of the Programme of Government, which includes a commitment to introduce electronic prescribing in NHS Wales. So as a reminder, on the screen is our vision statement for digital medicines programs, and is centered on making the prescribing, dispensing and administration of medicines everywhere in Wales easier, safer, more efficient and effective for both patients and professionals through digital. So everything we do in the digital medicine space is all aligned to realising this vision statement. To deliver this vision, there were originally 4 main areas of work which we were taking forward. I'll quickly touch upon those. So starting at the top, we've got the Primary Care Electronic Prescription Service Programme, also known as EPS. At a really high level, that means we are taking forward and adopting NHS England technology, which allows a prescription which is originated from a GP practice to be sent to a patient's nominated community pharmacy or dispenser of choice. In the secondary care space, we are taking forward the Secondary Care Electronic Prescribing and Medicines Administration Programme, also known as EPMA, where we've adopted a multi-vendor framework approach, where health boards and trusts have a choice of 3 suppliers to enter into contractual arrangement to deploy e-prescribing capabilities across every ward and every hospital in Wales. The third area then, which is the Patient Access Project, and this is around making additional medicines related features available within the NHS Wales app. So working very closely with our Digital Services for Publics and Patients programme. And the fourth and final area then, which is seen as truly transformational, is around delivering a shared medicines record. So this is around delivering a consolidated medicines, allergies and intolerance record for every patient in Wales, which can be accessed at the point of care, which one removes the need for patients to share and keep repeating the same information, but also means that information is available at the point of care when clinical decisions are made. So in terms of the Primary Care Electronic Prescription Service Programme, as I said, we're adopting NHS England technology. It's quite a complex programme with many touch points. We are working with 370 GP practices in Wales, almost 700 community pharmacies. We're also working with NHS England to adopt their technology. The additional challenges that we have 7 community pharmacy patient medication record system suppliers in Wales. We're also working in collaboration with the NHS Wales Shared Services Partnership, because they typically receive medicines dispense claims from our pharmacies to process payment. We're now working with 1 GP system supplier, and we also have 4 appliance dispensers in Wales, all of which we're working with to enable that prescription to be sent digitally to a patient's nominated community pharmacy, and for medicines dispense claims to be sent digitally as well, so entirely removing the paper from that process. So in terms of the key benefits, so the first is giving back time to GPs. So with EPS, there's no need to print or wet sign prescriptions. So myself, I go to my local GP. Typically, they create the prescription digitally, but then they print it and hand me the paper form, which I take or to my pharmacy where it's collected. There's no longer a need to do that. The prescription can be signed digitally and sent digitally to the patient's nominated community pharmacy. And what that does, it improves patient convenience. So patients no longer need to visit the surgery just to collect prescriptions. And similarly, the added benefit for pharmacies is they no longer need to send drivers purely just to collect those prescriptions, because they're sent pretty much in real time at the point that they're signed digitally. And one of the key benefits, which I've got some sound bites late in the presentation to give you some feedback from our users, is the prescription tracking tool, which is available in EPS. And that provides complete visibility on an audit trail on the status of a GP prescription. So if a patient needs to understand what the status is, they could contact the surgery. Instead of the surgery contacting the community pharmacy, or likewise, they can log on to EPS, view that prescription status tracking tool, and see the status of that prescription. Similarly, with moving to digital, it removes the risks with the reduction in lost paper prescriptions. And again, it's a reduction in transportation needs. So at the end of each month, community pharmacies will submit claims to NHS Wales Shared Services Partnership for medicines reimbursement. With EPS, they can now be sent digitally, so there's no need to send drivers or for those to be sent to the post as well. And the final benefit to add is that EPS also offers the opportunity to save millions of prescriptions for being printed every year. I think the latest data shows there are 81 million prescription items generated in primary care. EPS offers the opportunity for those to be sent digitally, which helps achieve or is a step towards achieving our goal of delivering a paper-light NHS Wales, as well as supporting the green agenda. So the key part of the presentation is to demonstrate what we've taken forward and progressed the last 12 months as the last committee. So we reached a number of key milestones. So in January 2025 this year, as I said, there were 7 community pharmacy patient medication record system suppliers in Wales, all who needed to do complete development to enable EPS and to receive a prescription digitally from a GP practice. That has happened. As a result of that, we've really seen our usage stats really start to take off. Similarly, in June of this year, 2025, we've seen all of the dispensing appliance contractors in Wales complete development and short use EPS in Wales. It's now in use across all health board areas, and the stats are slightly updated since I've produced this report. We're now live in 25% of GP practice in Wales, 60% of community pharmacies, and all DACs are using EPS, with 4.6 million prescription items dispensed using EPS as well. Another key milestone to highlight is that of the Welsh Government milestone, which was for us to deliver and be live in 60% of EPS 60% of community pharmacies by March 2026. Pleased to say that we've already achieved that in Q1, so ahead of schedule, and we're continuing with our national rollouts, and we anticipate to be live in 43% of GP practices by the end of this financial year, by 31st of March. So we're very much in the implementation phase now. All the readiness activities and development has been completed. We're also exploring other opportunities where EPS can bring benefits to both clinicians and patients, and we're working in collaboration with the National 6 Goals programme, and we're taking forward readiness to test the use of EPS in urgent primary care services settings. And we've identified Swansea Bay University Health Board to be that test location, and we're planning to complete that testing early in the new calendar year. Secondly, we've worked with NWSSP to develop a public-facing implementation dashboard, which the public can log on to get an indication and idea of whether the GP practice is live and whether the surrounding community pharmacies have got the capability to receive their prescription digitally as well. So on the slide, we've got a couple of slides now just to summarise and present some data which may have used just to give an indication of the uptake of EPS. So as a reminder, we first went live with EPS in Rail in November 2023, and between November 2023 and January 2025, there was an awful lot of work being taken forward with the community pharmacy system suppliers, one to complete development to use EPS and to go through the necessary testing. And as I said, we reached that milestone in January where all suppliers were assured to use EPS. And at that point, we were typically processing almost 250,000 of prescription items per month via EPS. By June, we've seen that exponential growth, where we're now seeing over 700k items being processed via EPS. And I'm pleased to say in July, we've now reached 1 million prescription items being dispensed via EPS. We're really seeing significant growth now that we've got all those system suppliers on board to use EPS. In terms of the prescription types that are being sent, the majority, so almost 90% of prescriptions are repeat prescriptions via EPS, followed by 9% acute prescriptions and 2 by electronic repeat dispense prescriptions. There is an opportunity to increase the use of ERDs, electronic repeat dispense prescriptions. Feedback we've had from GPs is that the paper-based process was very cumbersome, but there's an opportunity now we've transitioned to that to electronic and digital means. There may be an increase in uptake in that area. This slide presents the rollouts and adoption in each health board area. So as I said, we're live all across Wales. As of June, 20% of community GPs were live with EPS. In July, that's gone up to 25%. The target, we're aiming to be live in 50% of GPs by May 2026. And based on current resource plans, we're aiming to complete rollout across GPs by September 2027. although there is an ambition to bring that forward, but that is dependent on additional funding being made available to the programme to meet that requirement. So I've just got a couple of sound bites of feedback from stakeholders and users of the system. I won't read them verbatim, but we've got the initial go live site in Rill, which shared EPS is the best thing we've ever done. The GP has more time for patient care. We love it. Another practice in North Wales, we're receiving fewer phone calls to trace prescriptions and using less paper. EPS has been a massive change for the better for the farms. It's saved so much time already. We no longer have to call the GP numerous times a day to track down prescriptions. Our patients have really noticed the difference and have been surprised by how much quicker it can be. They don't have to bring a piece of paper, and by the time they get to us, the prescription has been dispensed and is waiting on the shelf. So that's that patient experience and benefit. We're seeing an approximate 75% reduction in the paper prescriptions being processed by the reception for sign-in, and we felt supported throughout. Our prescriptions no longer go missing, and it's better than we ever expected. It's made a huge difference in the pharmacy, completely changing the workflows to increase efficiency. So these are some of the early feedback and comments we're getting from end users, and we plan to do a further benefits realization report in Q4, where we hope to get even more positive comments from pharmacies, community and GPs alike. So in terms of the next steps then, what's our plans for between now and the end of the financial year? So we're going to continue with the EPS implementation schedule. As I said, we hope to be live in 43% of GP practice by the end of March. We'll continue the road to community pharmacies, and we're targeting 80% of those to be live again by the end of March. We're currently in conversations with Welsh Government at how we transition EPS to a fully operationally supported national service. So those conversations are continuing. We want to gather more data on the benefits that are being realised as part of this service. So we plan to deliver a report in March, which will be shared with our National Programme Board. And as I said, we're taking forward testing within urgent primary care services to assure EPS in readiness to roll out to all urgent primary care services across Wales. And that's in collaboration with the National Six Goals Programme. And we are looking at other opportunities. So there are opportunities where in hospital outpatients, there are a cohort of prescription types which could be sent to a community pharmacy to be dispensed. We are looking at opportunities of how EPS could support that. There's been recent pilots in England, which we're looking to learn from. So we're currently having conversations internally with both the National EPMA programme, EPS and Welsh Government around the opportunity to take that forward as well. So moving on to secondary care, as I said, we're taking forward the secondary care electronic prescribing and medicines administration programme. The scope of the programme is to deploy electronic prescribing and medicines administration in every hospital and every ward in Wales. It's a nationally governed programme, but it's procured and deployed locally. And our ambition is to introduce closed-loop medicines dispensing, which is where you integrate EPMAs with the All Wales Pharmacy Stock Control System to remove paper from medicines orders, which are out of stock on the hospital ward, and to introduce closed-loop medicines administration. That's where typically you scan the patient's barcode, wristband, identify the patient, scan the medications, so it's a clinical safety check, and we record that in administration digitally. So it's that will deliver a completely digital process for prescribing, ordering, dispensing, and administering the medicines. That's the gold standard that we're trying to achieve. In terms of the national programme, we have a very key role in delivering 8 national integrations, which will allow these EPMAs to integrate with the national architecture and allow information to be shared across applications and health board organisational boundaries. To do that, we've established a national technical and clinical assurance group. So we have technical expertise, clinicians all across Wales, which meet monthly, where we aim to configure EPMAs as standardised as possible to remove unwanted variation. And we also have a community of knowledge and action group called COCA. This serves as an opportunity to share best practices. So we invite speakers from other health organisations, Scotland, England, to share their key lessons learned with the EPMA implementation to make sure that we don't repeat those in Wales. So we're giving health boards and the national programme every opportunity to deploy these EPMAs safely and based on lessons learned from other areas. In terms of the key benefits, I'll touch upon these lightly. So obviously the first one is reducing the use of paper. So EPMA reduces paper-based medicines charts, which we're told often are misunderstood or go missing. So we're looking to replace those with digital mechanisms, which could be accessed by multiple people at the same time. Typically with the paper medicines chart, if someone picks it up, takes out the ward, it's sort of locked down to one healthcare provider or professional. It generates time savings as well, so it eliminates the need to search for paper charts, freeing up clinical time. One of the key benefits is it enables faster and safer medicines reconciliation on patient hospital administration. So one of the first things clinicians and pharmacists do when a patient is admitted to an inpatient bed is to get a medicines record and reconcile the medicines. With EPMA, and when they've completed development to use the shared medicines record, they will be able to view a patient's medicines record of the SMR, and they'll be able to write that information within EPMA, removing the need to transcribe, which we know is fraught with risks and errors. Go digital as well improves the legibility and accessibility, which so removes the risk with illegible handwriting, reducing the risk of misinterpretation. And again, one of the other key benefits with EPMA, it has inbuilt clinical decision support, which provides automated alerts for drug and allergies interactions. So if you attempt to prescribe, I don't know, for example, penicillin for someone who has an allergy to penicillin, the EPMA will provide that alert. So we're helping to prevent harm and adverse drug reactions to patients. And again, what is a key component to enable this is the EPMAs are procured to use standard technology and data standards. So they will be capturing and using DMD, so data for medicines and devices, as the single language for medicines, which means we can store that within a shared medicine record and make it interoperable. And we use the SNOMED CT for recording allergies. So this promises then that we can share that information, one with the shared medicine record to deliver that consolidated record, and we can make that available to other applications and to also do deep dives on that data. So we've got consistent language, which allows us to do that data interpretation. I won't go into a huge amount of detail here, but this is more for information, but these are the national integrations and APIs the national program is delivering. In summary, we're allowing the patient lists to be viewed in EPMA, whether that be for inpatients and outpatients. We're making a agreed set of test results to be available in EPMA to support safer prescribing. Another thing which end users are very keen for is to make or enable the EPMA to be launched from within the WCP patient record. So if you're in the WCP patient record, viewing test results, images, documents, you need to prescribe medicines. We've developed a staple link so you can open the EPMA in that patient contacts window without the need to then re-enter your username and password. So it's improving that end user experience. Another integration we're delivering is the ability to send the hospital discharge advice letter back to GPs digitally using our existing technology and making a copy available in the National Care Document Repository, so that can be viewed in the Welsh Clinical Portal and other applications. And the key one is around the shared medicines record application program interface. As I said, that's a really key deliverable for us to realise that vision of a single medicines and allergies and transfer record. And we've now developed that API, which is available for consumers to request access. So in terms of progress, the last 12 months, so 6 health boards have signed contracts from the multi-vendor framework. They are Cardiff Vale, Cumtaff Maganog, Betty Cadwallader, Powys and Iron Bevan and Howell Dda. We do have a hybrid of systems, so we have health boards who have signed contracts with BET, System C and Nerve Centre. I've got a slide later on which will show that landscape, and that really highlights the importance of interoperability. If we've got multiple systems being deployed across Wales, it's really important that we meet interoperability standards so we can make sure that data is not locked down into that EPMA or health board. The national integration is in flight, and we're making this available to health boards to start testing in their testing routes with the EPMA supplier. Pleased to share we had our first EPMA go live from the framework with Cardiff Vale in July last month, and they're using a national integration to send the discharge advice letter to GPs and within our document repository. The national technical activity assurance groups are continuing, the same as COCA, and we've also produced a national specification to deliver closed loop medicines dispensing, so integration with our Always Pharmacy stock control system, and that's been reviewed. And we've commenced that, as I said, that outpatient discovery for potentially enabling EPS for those prescriptions in a hospital setting. So the landscape of QDPMAs, as you can see, we've got Betsy, Powys, Howell Dda, and Iron Bevan all signed contracts with Beta. Cumtaff, Morganic, and Cardiff Vale signed contracts with Nerve Centre, and Swansea Bay were the Pathfinder site prior to the programme with System C. So we do have a hybrid, a mixed economy. As I said, it's really important that we work with them to make their data available in the shared medicine records. So if you do have a patient who transfers from an Iron Bevan, who has a better EPMA, and is later treated in Cumtaff, who has a Nerve Centre, they can access the information from both those systems, so we ensure that continuity of care. In terms of the next steps, so we'll continue to deliver the national integrations and APIs, which we deployed to health boards test environments. We are working with health boards to go through and complete the Welsh Informatics Assurance Group process, which provides that independent assurance review to make sure that we're deploying safe systems. We'll onboard the EPA suppliers on the multi-vendor framework to the API to make sure they can read and write data to our national repository. Complete that on patients discovery. Continue with a number of go lives for this calendar year. As I said, we're live with Carver Vale already, but we're working with Powys, Betsy, Cumtaf health boards to plan their early adopter go lives this calendar year, and also working with the Nine Bevan Hold to plan for their go lives early in 2026. And again, similar to EPS, we want to start doing interim benefits realization reports to show early, I guess, our return on investment and what the benefits are to both patients and to health professionals. Just got a couple of slides left. So in terms of the Shared Medicines Record Project, as a reminder, we're looking to deliver a single record of prescribed medicines and allergies for every patient in Wales, all in one place, which means patients don't have to keep re-providing the medicines information whenever they see a healthcare professional. And that, again, for clinicians, what that does, it removes the need to transcribe from one system to another, and it provides a consolidated medicines and allergies record, which can feed on national data resource, which will provide us with that rich data and data intelligence so we can do those deep dives. So in terms of the progress, the last 12 months, the project has transitioned to be governed under the Secretary Care EPMA program, which made sense because they work hand in hand. We've published the Shared Medicines Record API, which is on the consumer platform, and it's available in the sandbox, user acceptance test and production environments, and health boards are working through that progress now. The API itself enables medicines and allergies and intolerances information to be recorded in the SMR and GP system to be written into assured systems. And it also populates the hospital discharge advice letter at the point of discharge. Because we've got this sort of landscape where we've got multiple EPMAs being deployed, we have published a Welsh Health Circular in January, which mandated the use of the Dictionary for Medicines and Devices to make sure we use the common language for medicines. And we've also published a technical guidance document, which we've made available to the EPMA suppliers to help them with the readiness work to onboard and use the SMR API. We've transferred knowledge to the Care Data Repository team because ultimately they're going to be supporting the SMR and its API when operational. And the key thing that we're taking forward at the moment, which we hope to complete in coming weeks, is that we're looking to migrate some allergies and intolerances from a legacy data repository into the SMR so we can expose that, make that available to other applications. And on the screen, this is a dashboard which the team maintain. It just gives a snapshot of the SMR API onboarding status by health boards. So you can see in the user acceptance testing environment, we've got 2 health boards, BCU and Carver Vale, who have access to make sure the EPMAs can start testing. And we're working hand in hand with them to help with other health boards to get them on board as soon as possible so we can start realizing that vision and getting that data in the Shared Medicines record. I've got 2 slides left. So in terms of the patient access project, what have we achieved in the last 12 months? So as a reminder, we were making additional medicines features available in the app. One which we were taking forward was the push ready notification. So this is like a bit like Amazon. In the NHS Wales app, the user or patients notified when their prescriptions are available from the Acuity Pharmacy. That's live in 2 out of the 7 Acuity pharmacies, and we're almost 10,000 notifications have been sent to the NHS Wales app. The second feature which we were taking forward was the ability to nominate a community pharmacy in the app to receive a prescription digitally from a GP. That's in development and being managed by the DSPP program, and that's planned to be delivered in the coming months. We're mindful that we can learn an awful lot from NHS England and England same likewise. So we've established a joint working group to see where there's opportunities to align the apps. We've identified future pipeline medicines features which stakeholders have requested. So we've shared that now and transferred that to the DSPP program. And the project is officially closed from being governed under digital medicines, and all residual activities now transferred to the digital services for patients and public program to be governed under a new NHS Wales app digital medicines project board. Diolch, appreciate there's a lot of information there, so I'm happy to take any questions you may have.
Great, thank you, Lawrence. That's a really good summary, lots of good progress. We've got a couple of hands up, so let's go to Ewan first and then to Rowan.
Thank you very much, David. Before others come in with questions and comments, I just want to say thank you to Lawrence for a really clean, really very clear presentation. And I think that reflects the tight management that we have across these programs. It's a credit to the teams that are working on these programs. I want to pull out a couple of things that maybe are in the background, partly learning and partly reflection. So the first is thanks to some really key partners. This is a really complex environment. There are 7 pharmacy system providers. There are multiple EPMA systems. There are health boards that own the contracts on those. Those health boards are directly funded by the Welsh Government and reporting in terms of accountability directly to the Welsh Government. So there's a lot of choreography which is needed here. And we've also needed some innovative funding arrangements. So the choreography first, the independent chairs on these programs, Jenny Pugh-Jones and Leslie Hewer, but also particularly Andrew Evans, who is the Chief Pharmacy Officer inside Welsh Government. Most of our major programs have a Welsh Government digital team sponsor and also a policy lead sponsor. Andrew has been extremely hands-on, and I think really, really supportive in keeping the coordination and the coherence between these multiple programs. One of the challenges that we had with the community pharmacy systems was that there's no direct contractual relationship between us or the health boards and those system providers. They're purchased by the pharmacies themselves. So working with the Life Sciences Hub, there's an innovative community pharmacy systems innovation fund, I think CPSIF is called, which is effectively grant funding to enable the functionality in those systems. I think that's an innovative approach in Wales, and I think that's worked very, very well. And I just wanted to pay credit to the Life Sciences Hub for the way that has worked and plugged into the more conventionally directly funded program. The last thing that I want to say is that the pace of the delivery of these programs has been maintained over the last year and a half, but during that period, in sort of 2.5 to 3 cycles, the Welsh Government has either reduced or asked us to reduce the funding allocations to these national programs. So over the last 18 months, around 40% of the running cost of these national programs has been taken out of the programs without compromising delivery. I think that's a really impressive result. It's drawn on resources and capacity from other sources. It's also reflected completing certain phases early in order to stand them down sooner than the original program plan would have suggested, and a variety of other innovative sort of funding, looking for efficiencies everywhere. That doesn't come out that prominently in the reporting, but I think it's an absolute credit to the team to take that amount of efficiency funding out. And that efficiency funding has been released into other programs that have needed more money because they're facing their own problems. That is portfolio management in action, I guess. Some of it has been triggered by the Welsh Government in terms of its choices around where to deploy the Digital Priorities Investment Fund. But again, to maintain the pace of delivery while at the same time driving that kind of cost engineering through these programs, I think is a really impressive achievement. So I just wanted to mention that.
No, thanks, Ivan. There's some really useful context there, particularly around the reduction in running costs. Rowan.
So thank you both. Right. So Lawrence, really kind of comprehensive presentation and deep on detail. And thank you, Ivan, for that information. But I think in combination, that kind of goes to the heart of the challenge here. Because from my perspective, the electronic prescribing, the key benefit is patient safety. What going to electronic prescribing means is more accurate transferring of information between the prescribing clinician and the dispensing clinician, right? And that that is obviously a good thing because it means that what is dispensed is more accurate. The path to a shared medicines record means that the prescribing clinician has the benefit of sight of both what the person in front of him has been prescribed in a either primary or secondary healthcare setting, depending on which side of the aisle, if you like, they're in. And at the moment, clinicians have to ask patients for that, and patients it's hard. I mean, I work in the biopharma industry, and the names for drug have me kind of howling in laughter in the aisles. So goodness knows if you're on 6 or 7 drugs, how you're really supposed to recall the name of the pink one, right, that you take twice a day. So I think my comment is that we don't lock what we're doing around this enabling patient safety message, which is at the core of a lot of what we do. And this program is going really well.
Mm.
And really, we want to be creating the case to go faster. So, Ivan, I kind of, huge kind of sympathy for your optimistic glass half full. We're delivering while taking cost out. But I have to ask the question from a sort of use of public funds and efficiency across the NHS would be, what if we'd been able to maintain investment and go faster? And there's the theoretical answer to that, and there's also the practical answer, given how much the DDAP profession in health boards and across this wider ecosystem. Ivan, you highlighted that really nicely with the community pharmacies. Could, how much faster could they go with all the other priorities they have? So it's really a more of a sort of challenge to the program to talk us up, but also to think about what is the opportunity cost of having to, throttle back some of these programs to save cost, given that fundamentally this is a patient safety piece. So that's my sort of takeaway from this, Lawrence, and that's not to diminish anything that you've done over the last 12 months. Is phenomenal, right? But I think we have to challenge would we have enabled greater productivity with the NHS, more patient safety, had we been able to go a bit faster? And I really like, Ivan, the fact that we found those innovative funding mechanisms by considering the wider ecosystem. Ultimately, we're not responsible. We don't hold the ring for making these decisions. We have to kind of, but I'd like to see those conversations happening somewhere. So, do those conversations happen is the question that this all comes down to.
Okay, even before I bring you in, I had a question which is related, so I better ask it now, which is, in Lawrence's presentation for EPS, we're looking to complete rollout by September 27, but there was a comment about requiring additional funding. So I'd like a little bit more clarity, because I think what Rowan is saying is we should be trying to go faster, and what Lawrence is saying is we'd like to, but we don't necessarily have all the funding. So I think the two are linked. So perhaps even, or Lawrence, you could comment.
Yeah, absolutely. Thanks, David and Rowan. So that's what I was going to suggest, was that Lawrence would come back and talk about the options that we've explored and the conversations that we're having with Welsh Government to go faster in EPS, where we've got a direct line of sight to the pace that we are going at and to the constraints, some of which are linked to the GP migration that Sam will give an update on later on in the second half of the meeting. I was going to cover EPMA. EPMA is the same logic holds. If there is patient benefit, if there's a reduction in harm and an improvement in safety and quality of healthcare service delivery, then you should go as fast as you can. The national EPMA program is different in terms of its typology, I suppose I would say, to the EPS program, in that the national EPMA program is a coordinating and knowledge sharing function that seeks to support health boards to align in the implementation of their local EPMA programs. So each local organisation has its own EPMA implementation program. They are directly funded by Welsh Government. They report directly to Welsh Government. And we don't have a full line of sight even on the amounts of the funding allocation to those health boards. And those timetables do move around. It's fantastic to see Cardiff going live in July. the original plan for go live was January, which was rescheduled to March and then to June and to July. That's not in any way a criticism of Cardiff. We know that our own programs have to be rescheduled regularly and repeatedly because of dependency factors and contextual factors, and we are extremely conscious, and again we'll see some of this later on, that health boards are absolutely flat out at the moment on LIMS 2 and PACS as major priority programs that are complex and that are sucking in resources in their local implementation teams. So I think that's a long way of saying that I absolutely agree with the point, and DHEW certainly would advocate for going more quickly on the basis of realized benefits, but health boards are not accountable to us for that, and neither does the funding run through us to them to drive that agenda. So that's an agenda for Welsh Government to manage through its own direct governance and DPIP allocation management to those health boards, with us all working together in concert, so that our elements, like the shared medicines record, the knowledge, the standards and the DMND, etc., that we provide those on time to enable health boards to not have any dependencies on us, but they will always have their own local pressures.
Okay, thanks. Lawrence?
Thanks, Chair. Just wanted to comment on the EPS. So what I didn't call out in the presentation, which I should probably have done, is the support that we get from Sam Hall's area with primary care and mental health. So we fund 6 EPS implementation facilitators, because that's what our budget allows us to do. And that's a run rate of about 12 to 13 GB practices that we can support to go live per month, which brings us to the September 2027 date. I agree. I'd love to go faster. I think the benefits are all there to see. One of the challenges we've got is that we've had I think a circa 30% budget reduction this year, which meant there is a trade-off in scope. There's a trade-off in timelines. But what we have done with Welsh Government, because they are keen for us to go faster with EPS, we do have the dependency for the GP migration to be completed before we can do that, because we go live with Optum GPs. But we have highlighted the additional resources and people and funders required for us to complete and bring that forward to November 2026. That has been shared with Welsh Government. We haven't had confirmation of additional funding to be made available. But the reality is that we are working within the confines and restrictions of the budget, and that's the quickest that we can go with the budget that's allocated to us at the moment.
Rowan, do you want to come back and take this last question and we'll move on?
Thank you. One question, if someone could let me know, is what is the time scale for achieving a shared medicines record? You know, not necessarily across Wales, but, you know, percentage of the population covered or something like that, because that seems to be would be a useful metric to track, because I think that goes to the core. And Ridian, tell me if I'm wrong, but the shared medicines record is the sort of focus for creating, the core sort of patient safety.
Well, it's the only thing that we are really in control of, given the decision that policy needs to give the money and the choice to the health boards. Yes.
If we could look at perhaps tracking that, I think that would be really useful.
Yeah. So
Evan, do you want to come back in?
Yeah, I think it's a very difficult question to answer, and it comes back to discussions that whether you and other members will be familiar with about the difference between done from our perspective. The shared medicines record is technically available, is in production environment. The APIs to read and write medicines data to the SMR are provisioned and available. Compared to the definition of done, every system that should connect is connected, and all the data that should flow is flowing. And that is a different thing. There's a timetable for go live for the EPMA, so every health board will have EPMA go live by next financial year, as long as there isn't any further slippage in the timetable. That's what we would expect. It is included in the funding allocations from Welsh Government, and very often in the contract requirements too, between those health boards and their suppliers, that there will be an integration, and that data will flow using the FHIR interoperability standard through the mandated common APIs. But from our engagement, we are finding that some of the suppliers are struggling to meet that requirement. And there's been one change request so far to enable go live with that functionality to follow. So that is that the EPMA goes live as a standalone system. It brings all of the local benefits, but the data flows will follow in a further update and release of that product. And those are really difficult conversations, because clearly your choice is to say standards compliance overrides patient safety, or patients benefit if you deploy the EPMA on a standalone basis, and then you'll pick up the wider benefits of an SMR, which also are quite substantial. And those are choices for government. Those change controls notices go to government, not to us. We provide advice. So it's a very, very difficult question to answer. And I'm reversing it because it's difficult for us to track. If DHCW tracks and reports that, it gives the impression that we have control and authority, which we don't. Only government has control and authority in this space.
Yeah, no, I understand the points. Well made, Evan. Okay, thank you, Lawrence, for that presentation. Keep up the good work, please, and we'll see you again in 12 months' time. Let's now move on to Cancer Informatics Programme. This is being led by Alex, but just check if Evan or Rydia want to say anything before Alex comes in.
I'll say something at the end if you don't mind, Chair.
That sounds like a good plan. Over to you, Alex.
Thanks, Chair. I will just share my screen. I've provided some slides on the Cancer Informatics Programme, which, as Ivan said in his introduction to this section, is entering its closure phase. I still provided the standard annual assurance approach for this session, but I should note at the outset for committee members that we're anticipating that the programme will be closing in coming months, and that a programme closure report will follow in due course. Hopefully my slides will have loaded now.
I can see them. Thanks.
No, that's the digital maternity.
That's the maternity one. Apologies, my computer's on a go slow. Obviously, always
I was quite excited then because it looked simple.
It is simple. Spoiler alert for the next one. Hopefully this one will work now.
Yep, it's got the right title.
Good. That's a positive start. So yeah, apologies for the technical issues. I probably should have also introduced myself for the benefit of the recording. My name's Alex Purcell. I'm the head of Planned Care Programmes within Digital Health and Care Wales, and thanks again for inviting me to share the latest information on the Cancer Informatics Programme. So in terms of a history of the programme, the Cancer Informatics Programme was established to provide a new solution that meets the needs of users across the cancer service, with the primary aim of replacing the legacy CANISC solution. What that will do is it will provide new forms within the Welsh Clinical Portal in 4 kind of key project areas, which are the multidisciplinary team and cancer dataset e-forms, palliative care, data and reporting, and the screening and colposcopy service, all of which were using CANISC as their primary method of collecting, sharing patient information. The strategic and policy alignment for the programme was to make sure that we had a connected and efficient digital infrastructure in line with our DHCW digital strategy, that we improve the resilience and reliability of our services in line with Welsh Government's health and social care strategy, that we can provide better access to information, better information and technology for public services, and also to try and improve cancer services and outcomes across Wales in alignment with the Welsh Government Cancer Improvement Plan 2023-2026. So that strategic context led us to the decision that we would replace CANISC with the functionality within the existing platforms and services available to DHCW. CANISC itself is an end-of-life system. It holds a lot of information relating to cancer. It was the primary patient administration system for Velindre until the end of phase 1 of the Cancer Informatics Programme, which completed in 2022. And then since the establishment of phase 2 of the programme, we've been working then to remove all of the residual services using Canisk onto the new platform. So those servers that Canisk is running are all end of life. They receive regular security updates in order to make sure that they're aligned, but it's a challenge for us to continue to maintain those servers, maintain the software, and of course, because of the end-of-life nature of the software itself, it prevents us from making new improvements to the solution. So it's kind of essentially been in a limp-along state for a number of years while we've been working to migrate services onto new systems and functionality. We have anticipated the following benefits. They aren't necessarily transformational in their ambition. They're more around compliance, reduction of risk, the ability for us to move on to new and supported hardware, build capacity and resilience within our services, and I suppose as an addendum, providing information in a more comprehensive way with wider and more comprehensive reports to the service. So the kind of primary outcomes and objectives of the programme are around shoring up our cybersecurity position and getting us into a cancer system where we can provide periodic updates and improvements and enhancements to the software, which we were restricted by due to the nature of Canisk's software code. So we established a program with 4 key work streams, as I've mentioned. So the multidisciplinary team and cancer data set e-forms, data and reporting, palliative care, and screening and colposcopy. And in the next few slides, I'll run through the status of each of those work streams as we move towards the program closure. So this slide shows MDT. Apologies, the visual isn't entirely brilliant. However, that shows the uptake by all of the health boards of the cancer data set and multidisciplinary team forms. So you can see that for the various sites, cancer sites and health boards, everywhere where we were anticipating taking up that solution within the health boards has now been completed, and the last health boards to take the service was in January 2025. So we have drafted a project closure report that will be included within the wider program closure. We'll just be awaiting essentially the final program board in order to sign off on the completion of that deliverable. In terms of palliative care, there were 3 forms that were developed in order to replace the palliative care service that was used within Canisk. So these were patient preferences, the specialist palliative care form, and the specific multidisciplinary team form for palliative care. There were some challenges in the development of that form. So it was originally anticipated to go live in October 2024. That was delayed until January, and then for all health boards, the full rollout was completed in March 2025 with the final health board, which was Aneurin Bevan taking the forms up. We then, following the sort of warranty period for that, began the process of switching Canisk to read-only for palliative care users, which was completed on the 14th of April and has continued in read-only mode there, with palliative care forms being completed in the new WCP solution. So again, that project closure report has been drafted and is ready to go, awaiting final program closure. The data and reporting work stream, so dashboards are in a process of continued development in order to monitor our performance and enhance the services, provide feedback there. It also includes an increased use of information via the Welsh Care Record Service, so the development of radiotherapy treatment summaries for the various cancer networks in South East, South West and North Wales. So those are PDF forms that will be available within the Welsh Care Record Service that shows all of the treatment and radiotherapy that a patient has had in one place. At the moment, that's available in Velindre. There is testing ongoing within the South West Wales Cancer Network with a view to delivering that functionality as part of business as usual in the coming months. We have also provided the reports for all cancer areas now, apart from screening and colposcopy, which I'll discuss a little bit on the next slide. So there's dashboards and reports available on a regular basis for all cancer services, showing the usage of the systems, providing information for surveillance and cancer audit, and the availability of treatment summaries for the use in direct patient care. Our next steps will be to finalise the dashboards for screening and colposcopy, and then we'll complete the project closure report for this work stream as well, and that'll be incorporated into that final programme closure report. The last work stream is screening and colposcopy, and it's this one that has essentially been the dependency for us to actually complete the programme and close it down formally. So the colposcopy solution itself is a replacement solution that's made up of 3 parts. The first is PAS and WCP integration for the creation of appointments. The second part is a third-party system called Mediscan, which provides the appointment management and the image taking capability within the colposcopy clinic. And then the final element, which is an image viewer available within Welsh Clinical Portal, which allows the images taken to be reviewed by clinicians in settings outside of the colposcopy clinic. We have now deployed that. It was deployed on the 9th of July. However, it was originally intended to be deployed before the end of March. The reason for the delay was when we undertook initial testing of the solution. There were limitations within the testing process in that the colposcopy solution is only available within clinics using the Mediscan devices that connect to the machines in clinic. There are 18 of those in Wales, and there's no test functionality available. So in order to provide user acceptance testing, there was the creation of an image upload functionality. However, that didn't quite marry up to the image capture process, so we did some testing in live in order to prove that. And when we did that testing in live, there were a couple of issues that were identified both for the supplier to address and also for Digital Health and Care Wales. So the go live was postponed until Mediscan, the third-party supplier, were able to deliver a new version. That was delivered on the 18th of June, and then with consultation and engagement with the health boards, we took the decision to go live on the 9th of July, and the go live has been successful. So the graph that you can see there on the right-hand side of the screen is the colposcopy clinical record uptake within WCP. You can see that there are a small number of forms that were completed during that testing period between April and June, and then since we've gone live, over 1,000 records have been created within colposcopy since the 9th of July. So we've gone with a big bang approach, and it's been successful and has been delivered across all of the health boards in Wales. What we also need to do from a screening and colposcopy perspective is to complete the backload of the clinical history from CANISC. There's obviously decades plus of information for colposcopy clinics within CANISC, and that requires a big backload process in order to get that information into the Welsh Clinical Portal. We are undertaking some final checks on that backload process before running it. That will take around 3 weeks in order to complete. And then what we will be doing is, at the end of October, restricting front-end access to CANISC to allow for a 16-week period since the implementation of the solution on the 9th of July to kind of update any historical records that were included within the CANISC history until the 9th of July. So essentially the 16-week period needs to follow after that to make sure that updated records are available as they move over then from CANISC into Welsh Clinical Portal. The programme team, so activity with regards to the CANISC decommissioning has been impacted by the expiry of funding from Welsh Government. So the programme was funded by DPIF to the tune of around £2.5 million up until the end of March 2025. Subsequent cancer funding is around circa £1.6 million, which covers the business as usual team, but not programme activities. So we have been working on with a bit of a skeleton crew from a program perspective in order to drive that screening and colposcopy service live as the kind of last dependency for program closure. The team is now in place, though, from a business as usual point of view. So there's a cancer product manager working within the single record team who will maintain business as usual. A single record product board has been established, which will look at the backlog of improvements and enhancements to be made to the cancer solution, and the program closure report will detail the kind of full governance and transition from the program board mechanism into the single record product board and the various clinical input groups that will support that activity. So again, that's something that we'll address within the closure report over the coming weeks. Our final steps are then to produce that program closure report and hold the final cancer informatics program board. At the moment, the date for that hasn't been confirmed. The reports are in draft. There's some final inclusions that need to be incorporated for screening and colposcopy. We need to make the Canis solution read-only for the screening and colposcopy users once the Canis clinical history backload has been completed. We'll then remove the front-end access for Canis to be decommissioned. That'll be one of the actions that's picked up by the single record team as part of the program closure and handover activity. Data will be archived, and then, as I've mentioned previously, we'll be handing management of the program and the solution over to the single record product board and the product owner within the single record team. Just a final graph really in terms of user uptake and the progress that we've made in terms of getting systems and users off Canis. So you can see this is a 12-month view from August until July of this year. So you'll see there that as we started to implement functionality at the end of the last calendar year and the end of the financial year, that started to diminish. We've got a user base of around 190 users that are still actively using Canis to update colposcopy as well as some other residual activities. We are working actively with a single record team in order to bring that down, and we're anticipating that at the end of the Canis clinical history backload process, that number will reduce further before we decommission the solution and close down front-end access in October. So just to summarise the key successes, we have replaced Canis with the bespoke integrated solution within Welsh Clinical Portal and PAS. 18 cancer sites have got MDT and CDS forms, and that's in use across both health boards and Velindre. We've developed and deployed the specialist forms for palliative care, which replaced entirely the Canis functionality that was in use for palliative care. We've created several reporting dashboards, and we've introduced the screening and colposcopy solution. So we're in a good position now to formally close the programme and hand it over. That is my summary of the cancer informatics programme. So diolch yn fawr, colleagues, for listening to that presentation.
Okay, thanks, Alex. That's really a good summary. And I remember when I joined DHCW when we were formed, this was one of our big risks. So I'm glad to see we're at a point now where we can switch off Canis for good. Rowan.
I just want to say thank you. We've discussed Canis many times in the DGNS meeting. I'm really delighted that we're at this point, and I have said in DGNS that I will buy the entire team a cream tea when it's all done. So I'm repeating that offer, and I'm standing by to be told by Rydian when he feels it's delivered, so I can get my purse out. But I just really sincerely, Lawrence, thank you very much for this one.
Yeah, there's a lot of work that's gone into getting to where we are now, and I'm just looking forward to finally being able to switch it off. Rydian.
Thanks for the time to make a few comments, Chair. I'm not a big fan of cream teas, Rowan, but I do know what I do like. And I won't mention that. Anyway, right, in terms of the City Arms. Right, so what have I learned? Okay, well, But I'm in my 30th year of practice, and for 30 years I've been using Canis. That's there's no other aspect of my life where I have technology or software that has followed me that long. Canis was, I think Canis was 17 years old when the iPhone came out, the first one. No one on this call is using an iPhone 1 or whatever it is. How is it that the system tolerated the legacy software for so long? And how is it the system didn't coordinate in a way to make sure that we were on modern infrastructure, cyber secure? I think we can have a party when the CIRO says all is well and good. Okay, that'll be the first thing. The second thing is the closure report is going to be important because there are a number of lessons to be learned here. And when the program was broken into the three elements, the dependency of Velindre, so Velindre getting them off Canis onto WPAS and onto WCP, that was quite an achievement. Took a team effort, coordinated. The palliative care approach has been very good as well. The colposcopy has been probably the most tricky. Yet there's only 18 sites across Wales that do that, and that's a combination of change management and working with a supplier that has caused Alex some sleepless nights, and indeed we're still having some teething problems, particularly with imaging. So one of the things that I think needs to come out of it is that we need a plan for an image repository. It is a non-radiology image repository, and I'd expect to, within the next 6 months that we have a definitive plan about how we can do that. That will align with other cancer priorities in terms of dermatology particularly. We also have variation in the output from the suppliers of the external beam radiotherapy machines across Wales. A lack of standardization of codes, the usual sort of thing. We develop a plug, they've got a plug, it doesn't work, and therefore we have to do some sort of middleware. And we've got the same in the SACT program, so systemic anti-cancer treatment, which is some of our most expensive drugs that potentially improve the length of life, but can absolutely destroy quality of life. We need to understand who's getting what, why are they getting it, are they getting the benefit, and how we map that to the future of precision medicine, etc. So there's lots more work to do. On a positive, reorganisation of the team. So ring fence money from Welsh Government, predictable core revenue is really going to help us. We await for the NHS P&I to determine the structure of the cancer leadership. You'll be cited in the MAG review that there's reorganisation and a streamlining. There's some clinical positions that need to be determined before we get our list of the next things to do. And I'm also cognizant of the fact that our MAG, the MAG report, and indeed our remit letter, includes elements of cancer and functionality that we need to deliver. I'm confident that we have met the initial elements of that request, and that we will, by September, have met the vast majority of what is required by Christmas. So that is positive, but that's been a collective executive approach to ensure that the money has been included in our core, and that's one of the major lessons. Finally, because I don't want to occupy too much airtime, you'll be aware that there was a gateway review, there was an ideal health review, there's been a Welsh Audit Office review, and cancer is very much one of the performance targets within the current political discussions. Our function as a digital organisation is to ensure that those tools are performant and available, and that the data that is collected is exposed in a way that the system can be a learning system. So thank you.
Thank you for that additional context, Rydian. Rowan.
Yeah, and I think we're going to hear through this delivery committee that health isn't something that happens in individual silos, although med school often trains us to think of diseases as being specific systems. Data has to flow. Individuals who find themselves with a cancer diagnosis will also have other morbidities that will be treated. Records are, and this ability to integrate these systems so that clinicians and the broader community of professionals that are involved in their care have access to data in a timely fashion ultimately is expressed in quite esoteric things like the architecture, which I'm sure will the national architecture and these integration standards. I've said for many years, well before I joined DHCW, that providers that don't embrace open standards are on a path to make themselves less relevant to the delivery of care just because they can't share their information efficiently, because systems can't carry that overhead. So for what it's worth, I will share that because I think it has to be part of the storytelling around our architectures on why open standards are so important, because it drives to this central patient safety piece.
Thanks, Rowan. We'll take one last comment or question from Evan, and then we better move on to digital maternity Cymru.
Yep. Thanks, David. Yeah, and I think I'm going to be in the same sort of space as Rydian about some reflective comment and the learning that we take from the cancer program. Firstly, I hope that the committee feels that it can take assurance from the updates that Alex has given about understanding the inherent complexity of the task, how that was approached, and get a sense of grip and control. It's taken much longer than we wanted it to, but there are reasons for that, and I think that probably is the wider reflection. Before I was in DHW, I was in Welsh Government. I was the digital lead for 3 years. I think I did some things that I could have done differently and better. I did some things that I'm pleased that I did, and starting action to resolve the CANISC issue, I think, was one of those. But the more important reflection is that it was read on the National Risk Register from 2015. And the system, this is not the HW or its predecessor organization, NWIS, the system was unable to address that for several years, although it was a recognized risk issue at that national level, because it was a legacy system and there was really significant technical debt, and therefore, as a consequence, significant risk inherent. Members will know that currently we've got a National Market Architecture project, which is doing a current state assessment of our architecture and our systems estate across the entirety of NHS Wales. We're expecting around 2,000 or more systems, discrete systems, to be identified through that. Lots of those systems are going to be in the same space, I would imagine. Hopefully, none of them really large ones, I don't think, but there are going to be significant numbers of systems, and unpicking and unraveling the past is a real challenge. So it did take a lot longer. CANISC was an opaque black box type product on an antique coding language, where it was immensely difficult to find anybody who had the understanding of that to be able to reverse engineer it into the functionality that we needed into other places. Hopefully others will not be quite so difficult, but the learning from CANISC is really important, because we're going to have to go through this for several other systems. And the bigger lesson is not to get into this position again. That we need to address things in a timely fashion and keep an eye constantly on the need for technology refresh so that things don't get into this position. But for now, let's focus on where we are, where we've got to. Still a couple of dots on the I's and T's to cross before we can go for cream tea or other refreshments. But hopefully we will be there quite soon, which is an absolute relief and a benefit to the whole system.
Okay, thank you, Evan. Alex, my thanks as well for a programme well run. We've got 15 minutes left. Could you summarise the digital maternity Cymru for us, please?
Yes, thanks, Chair. So I haven't got slides. I did share a slide earlier, which was just a one-page kind of programme closure report summary. So that's included within the papers, I think. So I don't intend to share that again. Again, a slight victim of timing from the perspective of Digital Maternity Cymru programme, because obviously it's scheduled for its annual assurance update to the programme's delivery committee at this month, but we're also in the process of closing the programme down. I had intended to run through the programme closure report in a bit more detail in this session, because our original plan was that the programme board will meet for its final session on the 30th of July. Unfortunately, that has been postponed until Monday, the 11th of August. So again, another victim of timing. But I'm happy to just kind of run through the kind of key findings of that report. Obviously, on the premise that it's still in draft and that the final approved programme board report will follow for programme delivery committee members to review when that is formally completed. So just in terms of a potted history, the Digital Maternity Cymru programme was established back in 2023. There was a predecessor discovery project that ran during the 2022-23 financial year. The vision for the programme was to deliver a national digital maternity system across Wales to support clinicians and empowering women and birthing people to participate in high quality safe care. The programme aimed to procure a national digital maternity system and an application for women and birthing people that was integrated into the architecture with a set of standardised data sets and national audit capabilities. Welsh Government had funded the programme up until this financial year via DPIF, and the programme had worked to engage with the health boards and with third-party organisations, third sector organisations rather, across Wales in order to develop a set of requirements for procurement. The programme will be closed for two reasons. The first is the termination of that procurement. So originally the programme had gone out in October 2024 with a tender process. It ran the first stage of that tender process. It was anticipated that we would have a single supplier framework. We were intending to run a series of competitive dialogues as part of that process. But at the first stage, where we reviewed the initial tenders, we closed the procurement early and terminated the procurement because of a lack of competition. There was only one compliant bidder at the end of that initial evaluation process, which undermined the integrity of that competitive dialogue that we'd intended to run. The second reason for programme closure is a policy shift and a change in direction from Welsh Government. So following the termination of the procurement, Welsh Government wrote out to the health boards to advise that the health boards should be implementing a digital maternity system locally within the health boards, which I guess nullified to some degree or a large degree the requirement for a national programme. We were in a little bit of a hiatus, I suppose, for want of a better word, for that period between Christmas and April, May this year, where we were continuing to work on data standards in anticipation of the solutions being implemented by the health boards, but without really the programme board meeting or any kind of clear direction from Welsh Government around the process that the programme should be following. So thankfully, the Welsh Government wrote out at the start of May, I think it was actually the 1st of May, with a letter to confirm that the programme should be closed and that a separate project to be established in order to continue the work on standardisation, but with its own governance structure outside of that of the programme. So what that meant was that effectively a lot of the work streams that the programme would have been working on around configuration, testing and implementation, as well as obviously the procurement that was terminated, didn't materialise, and the programme closure report factors that in. So while the programme didn't meet its objectives, primarily due to that policy decision and the termination of the procurement, we did do some work that has applicability in other areas across NHS Wales. So as I previously mentioned, we made good progress in terms of the development of clinical standards for use in that system. So that has been picked up by the subsequent maternity data standards project, and that project is currently working on picking up that work, mapping data, comparing standards with England, and ultimately producing a data reporting standard for maternity and a data recording standard for maternity, which will be due to be published by the end of this financial year. There's also been substantial work around process mapping, understanding how the maternity system works across Wales, and as part of our programme closure activities, we've held sessions with the health boards where our business change team have shared the information that they gathered as part of those mapping exercises, so that it can be used to inform health board implementation processes and health board service design. We've also shared the outline business case, which was drafted as part of the planned procurement process and part of the programme, in order to help support the health boards in the development of their own local business cases for their respective implementations of the solution. So while it's not a great situation in terms of realizing benefits, we think that there are still benefits that will have had their inception within the program, but will become to be realized across the health boards once the implementation of their own local systems is completed. We've also been undertaking lessons learned activity as part of program closure, and the one-page report that was shared in advance of the meeting has a high-level summary there, but just for I guess just to note within the board, I think lessons around strategic clarity, making sure that from the outset there's an understanding of what's meant around Once for Wales and what the approaches should be, whether we're procuring a single instance or multiple instance solution, for example. All of that should be understood at the outset of the programme, that the commercial approaches then also reflect that, and that we are undertaking procurement processes that are proportionate to the complexity and scale of the requirements. I don't think necessarily that was an error on the part of the programme. However, I think that due to delays during the agreement of the procurement process, that led to the competitive dialogue process being truncated in terms of its timescales. And I think that perhaps one of the issues that we had with the quality of responses back from suppliers and the ultimate termination of the procurement was that there perhaps wasn't enough time for suppliers to digest all of the information that was provided to them. The approach to investment is probably something that we should be learning lessons from for future programs. The outline business case wasn't something that was in mind of the program straight from the outset, whereas to my view it should have been, and in future we need to make sure that if we are going to be working on investments in the multiple millions of pounds, that we're following that 5 case model straight from the outset of the program, and that stakeholders are aligned around those expectations moving forward. And then a final element really around the development of requirements and the ability of our clinical colleagues in order to support that activity. I think there were a lot of work that went into the development of the requirements, but there were a lot of stakeholders that were involved in that, and that perhaps led to a lack of clarity and uncertainty around buy-in. So I think for future programs of this nature, where we're looking at national procurement activity, that we've got a tightly constrained but well-supported team of clinical experts that can help provide the assurance around the development of requirements. And it's certainly a lesson that we're learning for the digital maternity data standards project, by having a commensurately sized clinical assurance group in order to review those standards. And the same, I think, should be done for requirements for procurements moving forward. So that's a kind of précis really of what the programme closure report will discuss, and what we'll be asking the board to approve as part of the final programme closure at next Monday's meeting.
Okay, thank you for that summary, Alex. Anybody got any questions for Alex on Digital Maternity Cymru? Even.
No questions. Just to say, I think that was a very helpful and considered summary. I just wanted maybe to give a bit of context. We have several programs that did not have a conventional OBC type program plan, and that includes both EPS and DPMA, as well as maternity. These were kicked off in sort of 2022, 21, 22, 23. That was a time when inside Welsh Government there was a very, very strong lead on digital policy coming from Lee Waters as Minister for Digital. to drive hard on digital agility and not to use explicitly not to use waterfall approaches, which is what an OBC ordinarily would accommodate. I think it's time to reflect on that, because using the learning that we've had from these programs, it's certainly not the case that you always need an OBC, as we've just had an update on EPS and EPMA showing that they're delivering effectively and well without having had a conventional waterfall at the beginning. But for maternity, maybe I think it would have helped, as Alex said, to have that kind of structure which would have locked down partner commitments and locked down a very clear plan. So I think we need to pull that together. We as an organization want to move towards product approaches which also are agile. So there's a lot which is moving about, and we need to be, I think, more intelligent about how we design the right method. Sometimes we need waterfall, sometimes we're better off with agility, and I think we need to work out how do we sensibly at the right time in the life cycle of the program decide which approach we're gonna have with more confidence is the right one. I guess the final comment on that is that there's been a lot of learning from programs over the last 18 to 24 months that has got a lot of inherent value, and we need to really focus on making sure that we can distill that and apply that learning now, because you learn a lot more from mistakes than you do from things that just go awfully smoothly.
Okay, yeah, that's a really good, strong point. I'll take one more comment from Rhaglenni, and then we'll go for a comfort break.
Thanks. I've got 3 or 4 things to say, David. The first one is to say that pregnancy is a condition and it's transient. The objective, and we know this, the objective is to enable the mum to be in the healthiest state possible at the point of conception, for the child to have a successful gestation, and for neonatologists not to be involved, for health visitors to ensure the child is safe and thriving in a home environment, preschool environment to be optimized to allow a child to enter school to get the benefits of education. The reason I articulate it like that is it's a pathway. Each one of those pathways has information and data and different healthcare professionals that need to see the stuff to understand what came before. We as an organization were quite robust in the advice that we gave. That is our job. And I'm confident that I discharge that duty to provide advice to policy leads, that this needs to be simple, that it needs to be vanilla across Wales, it needs to be accessible wherever a mum might go, and lessons learned from other nations who've tried this, we articulated. Anyway, the way it's worked out is the way it's worked out. One of the urban myths that I think we need to be cognizant of is that if you do things locally, it is faster with a national program, and I hope that comes out in the closure report, because it's important to understand that all of these things take time. Ivan's already articulated some delays in the EPMA program. Helpful belief, if I just buy that thing and work with a supplier, it'll all work quickly. These things are hard, and the expectation setting of the deliverable timeframes and the advice that perhaps policy leads get on that, we need to consider how we might do that better in the future. Thank you.
Thank you, Rhaglenni. Ron,
if you'll allow me one thing.
Yeah.
So I would just say that women's health, the label, sometimes kind of suggests that women's health is just one small slice of the overall healthcare pathway. In actual fact, women's health requirements are more than half of healthcare, and many of those things stem from exactly the process that Rhaglenni described. Enabling safe birth reduces the consequence and expense of the complications. So this is quite profound in terms of efficiency of NHS and productivity and everything else. as I said, I think some of the things that we're learning from programs isn't just related to maternity, and perhaps, establishing and publishing a paper on the things that we've learned would be very useful for the wider system, because we have to get the clinical experts and the digital experts to a pace of common understanding in order to make good choices about these things, and to work with ministers. So I think there is a bigger system lesson here that we need to think about how we can inform that wider conversation.
That's a really good point. Thank you, Rowan. Right, Alex, thank you for that update on Digital Maternity Cymru. We'll now take a 10-minute break. So if we could be back at 30 minutes past 11, we'll resume then. Can I remind everybody to turn their cameras and mute their microphones while we're on the break? Thank you. Morning, Sam. Thank you for joining us.
Okay, how are you, David?
I'm good, thank you. Looking forward to the summer holidays.
Yes, I'm off for 2 weeks actually from Monday, so looking forward to that. I'll spend a bit of time in North Wales, hopefully.
Excellent. Good part of the world to visit. We'll just give Ruth a second or two and then we'll restart. Even as well as dropped off, actually, I think. He was having connection problems.
Michelle, in case Ivan doesn't come back, are you okay to cover?
Oh, there he is.
Oh, he is there. And
Yes.
you're on mute, and I assumed that was yes, of course.
I said, of course, Laura, but there he is. That's very helpful.
Have you got a good connection, even?
I'm going to guess that's a no.
Hmm.
There are a few Teams challenges this morning.
There are. Tell you what we're going to do while we're waiting for even to get properly connected. Let's restart the meeting with the major programs report 5.1. We'll jump over the two that Evan are going to do and then come back to them when he joins properly. And let's go to Sam Lloyd for the Welsh Patient Admin Disaggregation Migration update. And then if Evan's available, we'll go back to him. Sam, over to you, please.
Thank you, David. So the, excuse me, the WPAS disaggregation program, which was obviously the work to migrate users migrate patients from the Bridgend Hospital to the CTM instance of WPAS from the Swansea Bay instance of WPAS. That work, after several years in the planning, concluded over the weekend of the 16th to the 19th of May this year. So we had a successful go live. The program is now in its closure phase. So we're in the process of writing up the closure report and then undertaking a lessons learned exercise to look at both the kind of short-term operational and tactical lessons to be learned, but also the longer-term strategic lessons around how a lot of this work was actually related to inter-organizational complexity and different ways of working, different ways of recording patient information, and so on. So just to sort of summarize where we are from a kind of program closure perspective. As I say, we did complete the go live weekend, 16th and 19th of May. Full system access was restored at 8 AM on the 19th of May, which was the Monday. We did hold to the dates that were scheduled. There was a bit of holding of nerve required, I think, because we weren't able to do as much testing as we had initially intended, and the scope of the migration also changed. But despite all of that, I think it went really well, and it was a good example of cross-organisational working. There was a huge amount of effort that was put into it by teams from DHCW, Swansea Bay, and Cwmtaf Morgannwg. I think this is a good opportunity to say thank you to everybody who was involved. We had a 2-week post-go-live warranty period to ensure system stability and resolution of any critical issues. There were some issues that arose in the post-go-live period, and there are still a few that are being worked through. So those particularly relate to the CETO clinical note application. There's demographics mismatching between from records that were migrated from Swansea Bay to Cwmtaf Morgannwg as a result of that, and that's still being worked through. There is the ongoing merge of duplicate records in the Cwmtaf Morgannwg PAS instance, which is also underway. And there's an issue with cash card scanning. So these are the cards that are used by clinicians when people are admitted into emergency departments to do the kind of initial assessment. Any cards that were scanned up to the 16th of May are viewable in the Swansea Bay clinical portal, but any that were scanned after are not. And that's because new cash cards are using the hospital number from the CTM PAS, whereas the Swansea Bay portal uses demographics from the Swansea Bay PAS. So another example of differences in the way that data is recorded that is causing ongoing issues. Some immediate feedback on challenges and lessons learned. So there were testing delays. I think just essentially the complexity of the program meant that we had to build an entire test environment which replicated a plethora of systems across the national infrastructure and architecture, which was really complicated to do. That took a lot longer than we had originally intended, which meant that the time available for testing was compressed, which, as I said earlier, meant that the confidence factor going into the migration was lower than we might have liked. That also meant that the full dress rehearsal that we were intending to do was reduced in its scope and became more of a dry run, which again had an impact on some confidence. The pre-production environment, despite the notwithstanding the complexity of establishing it, has actually become quite a useful asset for us now. So we will keep hold of that and use it for future work. It's the first time that we've ever had something that's as comprehensive as that for use in testing. So we'll continue with that. We were tracking issues across the three organisations closely in the run-up to and post go live. So we used Trello to manage those, and we had over 380 issues at one point, which were of varying severity in the immediate post go live situation, but that's reduced to 48 by July. So those issues have been actively worked through, and we are now just down to those last few kind of more knotty ones. But those are now being issued managed via BAU processes rather than formal program structures. There are some staff who are being retained at CTM to deal with some of those longer term data quality issues that we're working through. Funding for those, I think, goes up until the end of the financial year. So CTM are obviously concerned about what might happen at the end of that funding period if those issues haven't been resolved. But that's something that they're very much keeping an eye on. So I think those are the main points, really. So yeah, happy to take any questions. Thank you.
Right. Thanks, Sam. Ruth.
Thanks, Sam. It wouldn't be traditional if I didn't comment on this, because it's been somewhat of an irksome bee in my bonnet ever since the first day I set foot on this board, and it feels like we're getting closer and closer to not having to talk about WPAS migration at this meeting. So thank you for that. It's good to hear the progress. I think in the first half of the meeting we made some comments around how we avoid getting into a situation where we have that kind of technical legacy that we're struggling to manage. So I'll just reiterate the point that I always make. I think it's the lessons learned on this particular piece of work that's most important. We've had to work through this and struggle through this for a number of years in a situation we shouldn't have been in because it wasn't planned for it years ago. Just really keen to continue to hear about the lessons learned as we go through this process in terms of closing off the piece of work. So my thanks as ever to everybody who's been continuously pushing forward on this to see this through. Diolch.
Yeah,
thank you, Ruth.
Your sentiments, Ruth. Thanks. Rydian.
Thank you. I'm afraid to disappoint you, Ruth. It won't be the last time we talk about PAS migration. This particular thing has affected me in both aspects of my professional careers. As a clinician in Princess of Wales Hospital, the environment which is being lifted and shifted, and the ramifications continue to affect my clinical practice and understanding of waiting lists and the ability to see things, mainly because despite having standards And I'll mention Welsh Health Circular 2015-049 as the one that I always do. People continue to use localized hospital numbers, use different codes to code the same conditions, and it is a collective failure. I suppose the question here is, how are we going to stop that from happening going forward, Sam?
Yeah.
Good question, Rudy. And if you can come up with an answer, we'd be all very appreciative.
Yeah, I would be delighted if I could. But so I think just to respond to Ruth's points, I think the lessons learned, absolutely, you'd be very happy to bring back to this committee. And then to both Ruth and Ridian's points, I think what this does now give us the opportunity to do is, now that the PAS team have concluded this work, this program, we can now move on to trying to tackle some of those issues. It's not going to be a quick fix. I think we're all aware of that, but it does give us the opportunity to think about how we might tackle some of these coding issues and whether or not there are quick wins that we can find. And we need to start somewhere, don't we? This is a huge problem, but we can't afford to consider it to be intractable. So we've got to start somewhere. We've got to break it down into manageable chunks, and we've got to start making a dent in it. And I think now we've got the headspace that this program is concluded, we can start to consider how we do that.
Yeah. Okay. Thank you, Sam. Can't see any other questions for you, so we'll move on to National Data Resource, and we'll go to Evan for this one.
Well, let's see if video and audio work together. Can you hear me?
You did freeze for a second there, which worried me, but carry on. And
well, I'm on a 0.5 meg connection, so we'll see. And if it doesn't work, then I'll see if I can switch back to my phone. My 4G went down previously as well. Do you want me to go through the overview report quickly, scene setting, and then come NDR?
Yes, please.
Yep, thanks. And I won't divert us too far, so I'll go through it quite briefly. The report has been shared; it's in the papers, so members and anybody watching can see that. I just want to pull out a few things. One, at the last program delivery committee, we noted the audit report of the PMO. There was one recommendation from that audit report, which was to do with change controls. We've actioned that in terms of the management response. That's been confirmed as closed, so I just wanted to flag that. And the second thing I wanted to flag from the report was the ongoing work that we're doing around project management tooling, which means an online resource that we can use across all of our programs and projects, rather than working through manual documents, particularly PowerPoint slides and others, which is what we have been doing. That will firstly drive consistency, but also particularly drive reuse, particularly where we need to report to multiple different audiences, which we do as part of the escalation. Obviously, there's an even more intense scrutiny to Welsh Government, and there's new DDAT governance inside Welsh Government at the national level, so that will help us with reporting in that area. The final thing I want to comment there is that our first ambition and milestone is to deploy this across all DHCW managed programs and project teams by the autumn. But it's an all Wales license, and we've worked with some health boards who have already used something very similar using Microsoft Project. And so there'll be an opportunity to offer that more widely, because so many of our programs are collective or collaborative programs that involve external partners. So we will be able technically to do that. On the portfolio, just to flag, we'll go through the individual reports. But at the last meeting, we looked at the classification of major programs. We made some small changes to the numbers of programs that we have, and so the makeup of the list in this meeting is slightly different to the one from the last meeting. I won't go through which programs have stepped up and stepped down, because we'll be going through each of them individually. So unless any questions on the overall report, I'll go on to the National Data Resource. I think the highlight from Q1, so we're looking back at the reporting period Q1, is that for the first time we have live clinical data flowing to and from the CDR, which is the growth chart, which is surfaced in the Welsh Clinical Portal. And so I want to flag that. That is our intended future model. The future arrives in parts, but it's really important, and I think a major milestone that we've achieved that, which demonstrates the ability to push data to and from the CDR using FHIR as an API standard, and to surface that in an application like the Welsh Clinical Portal. So that will be the first of many, I hope. And secondly, and I'll pick some of this up in the NHS Wales app update or the TSPP update, is that alongside that, there's also work which has been done on exposing appointments and waiting list referrals from the Welsh PAS systems that we have across Wales through the CDR into the app. The chosen architecture that we have is that the app only connects to the CDR. So the NHS Wales app does not connect to many systems, which is our conventional. Our existing architecture is a sort of a many-to-many architecture. The app only surfaces from the CDR. So if you want to present appointments in the app, you send them to the CDR and then they will be there. That's an important architecture design. A lot of development work through the first 3 months of the year. So the first quarter and the pilot of that in Hywel, which I'll say a bit more about later, is live from the beginning of July. The other element on the NDR is comms engagement, working with our delivery partners. As you know, it's a federated program. There's been, shall we say, there's been a lot of intense dialogue around joint data controllership status within the NDR environment, providing assurance to boards and to other delivery partners about whether the appropriate model is one of DHW as a data processor or as a data controller, and for what purposes. It's been an involved discussion, which has included Chief Exec's peer group, Welsh Government, and a variety of other things. I think we're coming through that now with a degree of consensus. It is very important to us that we can have a stable legal framework for the sharing of data into the CDR. The mantra which is in the CDR business case is you have to be able to share data technically, but then you also need to be allowed to share data, which means the legal powers. So I think we're through that. But just to make sure that we're all on the same page, next week there's an NDR board development day. So for the first time, we'll be bringing the NDR board together, and we're drawing here on lessons learned from the PDC committee and from the SHA board, I think, in fact. So it'll be an in-person event for half a day, outside of the regular governance, the regular assurance governance, just to ensure that we have all of the partners aligned and that we can talk about the future and the very busy timetable that we have for the rest of this year, because the priority then will be accelerating the migration of data and the connection of new systems, stacking up the FHIR interfaces that we need to deliver so that everybody understands what those are, which sequence they will arrive, and how they work. So I really welcome that. I should also finally comment in passing that at the moment, there's no chair appointed to the NDR program board. John Peters, if you remember, stood down around about a year ago. Mike Emery, Chief Digital and Innovation Officer in the Welsh Government at the time, appointed himself as an interim chair for a 6-month period. That has come to an end. So we're without a chair. I'm chairing the program board meetings as the lead executive. This is our standard approach. If the chair is absent for any reason, then the lead executive will chair the program board meeting. But I've been very clear with our federated partners. I'm not appointing myself to be the chair of the NDR program. I'm only chairing program board meetings in the absence of a chair, and we're working with the Welsh Government team to identify a suitable chair, including through a meeting of all of the program chairs, which is scheduled in government offices at the beginning of September. So I welcome any questions on the NDR against that as an update.
Okay. Thanks for that, Ivan. What's your expectation around the timeline for appointing a chair? Have you got one?
Well, I haven't got one. It's not my appointment. So I haven't got a timeline, and I can't speak on behalf of the Welsh Government to commit them to a timeline. I think I think programs benefit from having appointed independent chairs. So I hope we can get there fairly soon. I'm obviously quite happy to continue to chair the program boards. In terms of assurance, I think the program boards are working effectively. The relationships in the end are healthy and they're fine. But it would be better to have an independent chair appointed.
Yeah, yeah. We've seen from previous meetings that having a chair is of significant value to the programme, so we'd welcome getting that closed up by Welsh Government sooner rather than later. Can't see any other questions for you, so if you want to move on to TSPP, please.
Great, thank you. So NHS Wales app is absolutely front and centre in terms of ministerial expectations. Throughout the first quarter of the year, the Cabinet Secretaries, I think it's kind of a summit with the leadership group, the Welsh Government response to the Ministerial Advisory Group recommendations, the Ministers' Digital Summit at the beginning of May, and further correspondence from the Cabinet Secretary in the last few weeks about improving performance together, which is an agenda for NHS Wales. All of them have made reference to the NHS Wales app. We have a very stable delivery plan for 25-26, what we call the silver plan. We were asked by the Minister, Sarah Murphy, to provide bronze, silver and gold options in February and March. She confirmed the silver roadmap, and we're absolutely focused on delivering that. It's quite a challenging timetable, but we're trying to hold to that. The first quarter saw two things of note for me to draw out. One is we delivered the Welsh Identity Verification Service early. So at ministerial request, that was scheduled originally for the end of May, but we delivered that during April in advance of the Digital Summit. So teams delivered that around 6 weeks early. And then the first pilot of outpatient appointments and of waiting list referrals, which we're working with Hywel Dda General Surgery outpatient clinics on, was 2 weeks late in delivering. So that was scheduled for the end of June. However, some key elements were scheduled for the same day that we had a data center outage. And so obviously those were then paused in relation to test environments. So we lost 2 weeks by the time we could reschedule those key elements. Kept Welsh Government fully informed all the way through that process, and we did go live 2 weeks late as replanned. So we're getting the functionality is there. We are finding some glitches in terms of exactly how appointments are being presented into the app. That's what we would expect from an alpha pilot. While we're doing that, we're also communicating with and briefing all of the other health boards so that they can start their onboarding, their readiness for onboarding of outpatient clinics. Because of the variation in the way the data is held and configured in Welsh PAS, this data comes from Welsh PAS, as we were just talking on the previous item, there are different configurations and different structures for data and different ways to manage outpatient clinics and lists in Welsh PAS. So there's an important element of, let's call it local assurance and readiness before enabling each outpatient clinic. So we're working with health board partners to ensure that they get a good run up, and we're working with Welsh Government to be able to give them the visibility of progress and deployment that they're looking for through to go live. Once we find out the issues with the pilot or the learning from the pilot, we should be in a position to then deploy rapidly across Wales. And I know that the ministers want to deploy very, very rapidly across Wales. But the overall assessment is that we're on track and on plan against the silver roadmap that has been agreed with ministers, and we've got a stable delivery runway on that.
Excellent. And good to see you making good progress. Any questions for Ivan on the NHS Wales app? No, I think you've given us a good summary. Even the only question I'd ask is, where are we with a full-blown public launch? Is that still work in progress in terms of a date?
Yes, we don't have a confirmed date. We've provided advice to the minister. So within the programme, if you recall from previous updates, there's a sort of an assessment matrix based on which we would give advice to the minister. We were planning to a September launch, but ministers are understandably looking for more assurance, particularly around consistency of the primary care offer.
Okay.
Which features have been enabled across which surgeries with a high degree of consistency.
Okay.
We understand that Welsh Government are working with the GP community through the GMS contract negotiations to try to provide that more consistent.
Okay, cool. Okay, hopefully there'll be progress soon. Sorry, even you occasionally pause, so I'm not sure whether you've stopped or it's just the connection's a bit poor. Okay, thanks. Right, no more questions on DSPP, so let's move on to Welsh Intensive Care Informatics System. And for this, I think we're going to Michelle, is that correct?
Absolutely, David. Happy to take that. Colleagues will recall we've had a number of conversations about this system, which is intended to support all of the critical care departments across our hospitals in Wales. So quite a key area. And the project was effectively on hold following a decision not to go live, which is about 18 months ago now. So I'm really pleased actually with critical care, because I think we've seen a bit of a turnaround. We're not entirely there yet, so I don't want to be too optimistic, but we've stood up a new board. We've got a new program oversight chair. You mentioned earlier, David, I would agree, having a good, strong program oversight chair has been really helpful. Mandy Riani, who was previously executive in one of our health boards, has come in and has taken on the chair. And we've stood up the new governance. So we've got a new board with a very clear understanding and membership in terms of what we're being asked to do. We've got a clinical advisory group that's been stood up now with good clinical representation from across our health boards and trusts. And we've got a technical advisory group as well with our digital colleagues. So I think we've got good mechanisms in place. We've had workshops with those people and a wider group of stakeholders to really understand the refinements that we need to make to the solution in order to be able to deploy it and for it to be effective and safe. So your colleagues again will recall there were some safety concerns that had previously been raised, which is the main reason we didn't go live. So my sense is we're making good progress. We've met as a board a couple of times now to discuss that. And we've got a key board coming up now in August when we will receive the recommendation from the clinical advisory group in terms of the key changes that are required. Those will then be taken by the supplier and worked up into a proposal. So end of September is a key decision point for WICIS, at which point we expect to present through the agreement with the programme board to Welsh Government a proposal which sets out, as I said, the key changes, the agreement across the health boards and trusts, and any kind of timing and funding requirements in order to deliver the programme going forwards. And that's quite a key decision point then with Welsh Government in terms of how and when we move forward. So good progress so far. I think that September decision point is quite key for us in terms of how the programme moves forward.
Fine. I think from what you've said, Michelle, we're on track for end of September in terms of getting the requirements sorted, and we've given the supplier enough time to come back with a estimate of what that would likely take. Yeah,
we are, David. It's quite tight, but I think it's really important that we maintain that timing so that we can start to make progress really and look at what can be delivered in the remainder of the year.
Okay. Yeah. Rowan.
Just one quick piece on that, because while we kind of work our way through this process and get to this shared understanding of what's required, we have a supplier that has a business to run and other expectations. So it's so important, as we've heard before on some of these other programs, that the supplier's ability to engage with the process and deliver is critical to our success. So have you got any sense of where their minds are and how they're being kept abreast of this process? You can share that on
I'm happy to share, and I think they would also be happy. I mean, they're still very much engaged in all of the work that's been going on. They've been involved in all the workshops. They are members of the programme board, so they sit alongside all the other members when we're discussing these issues and we're making decisions. I think that's really important. As I said, my sense is they are and continue to be very engaged. They've got a new web version of their product They've ported into that quite a lot of the developments that we're worked through with Wales, and they're still very keen to be able to deploy that across Wales. I think it's a good opportunity for them and for us, to be honest. So I've been really clear with them. Obviously, we've got that key decision point. So we are all clear, I think, that we're working to that point, and then we'll make an informed decision for them as well. So they need to be comfortable that they can make the changes, that works for them. And also, I'm sure they will be keen then to discuss with us how quickly we could deploy that, so that we could start to receive the benefit and they can start to receive some income against their investment. Reasonable point.
Thank you for that, Rowan. And we'll look forward to an update at our November committee meeting, that hopefully we've resolved that and we've got a clear way forward. So, Michelle, thank you for that. Can I ask you to move on to Radiology Information Systems procurement for us, please?
Okay, so really quick reminder. So this is the system that supports our radiology department. So there's the aspect that supports the booking of appointments and reporting, and then the other, so that's what we refer to as the radiology information system. And then we've got the PACS solution. So those hold the images that are taken from the scanners and are viewed by various clinicians. So this is a key system in the middle of the services that we provide across all of our hospitals and trusts in Wales. So where are we? We've got we've appointed a supplier some time ago now. I probably should say that this is coordinated through a national programme, but contracts are held locally by each health board, and decisions regarding implementation are taken locally within the health boards. So the good news, I think, since the last time we met, is that Powys is live. So Powys are now live. They're using the new solution to support their patients across their hospitals. So that's really positive. And that is the same solution that will be deployed across all of our other health boards and trusts. So that's a good a milestone that has been met, and the system is now operating effectively. BCU, who are our first big health board, we're planning to go live in July. That go live has been postponed. And that is largely because there were a couple of key technical issues. They were not ready to go live, and I think the health board made the right decision in July to say that they would push that back so that those issues could be addressed, and they are being addressed with the supplier. And that meant that they had to replan their go live. And I think it's not a case where you can just say maybe we'll just push it back a week or push it back 2 weeks. I think those key issues have been addressed. But from the health board's perspective, this is a big change for them. So they would have arranged things like rotas in terms of appropriate staffing. They need to make changes into some of their clinics, etc. So they've been through that replanning process, and we anticipate that they will now go live in September. And I think that they're feeling quite positive about that. And I think the good news, if you like, is the feedback from the clinical community is they're quite excited about the new solution. So it's just quite a big shift for them. And what they are also doing up in the north of Wales is they're bringing together multiple systems into one. So they previously operated with 3 systems, and they're bringing those into one, so that that will give them the benefit of being able to schedule resources and to have a kind of oversight right across their health board. So that's a big change and a big benefit for them, I think, up in BCU. Other health boards then, in terms of the RISP, have go live scheduled out to the end of this financial year. There are some changes that are being discussed in some of those dates. So some of the health boards are looking to push those dates back a bit. Different reasons within the different health boards. And I think the final health board in Arran Bevan are in discussions at the moment. They are anticipating that their date may move into April or May next financial year. And the key reason for me calling that out here, as I said, that's a health board decision really, is that will also impact, firstly, it impacts on the other health boards, and it will impact on us. So in terms of those impacts, there is a workshop scheduled at the beginning of September to sit down with all of the health boards to understand about those the impacts and some of the decisions that are being made locally, how they would impact across their neighbours, if you like. In terms of the impact on us, there's a couple of things really. One, we run the legacy radiology information system, so we have a system called RADIS, which is used by the majority of our health boards currently. So we're obviously migrating off of that product. So inside of our organisation, we would have been planning to transition off of the product and already, looking at new opportunities for the team. We want to retain the people who support that product within our organisation. So I know Sam would have been working with his folks to think about, okay, where do we want to move people? What are the opportunities for these folks to stay with us? So obviously, if we've got an extended period of support, we'll need to review that and think about how we maintain that support and any associated costs in terms of maintaining that support. And then there's also the issue with the programme team. So we had anticipated that RISP as a programme would be complete by the end of March. We'll now be looking at that to see whether we need to extend the life of the programme team if all of the health boards will not have migrated onto the new system. So bit of movement on RISP, and I think, as I say, some key lessons. The key talking point for me at the last RISP board was really about that impact. So making local decisions, but actually impacting other health boards, and how do we, how do we work on that together as a system? And I think that is where we come in really, and where we, that kind of coordinating support is turning out to be really key in this area.
Okay, great. Any questions from Michelle on RISP? Okay, just one from me then, Michelle. What are we hoping to get out of the workshop next week in terms of trying to act more as a whole rather than local decisions having an impact elsewhere without appearing to be obvious to the health board?
Yeah, there's a couple of things, to be honest, David. I think the main point is about the scheduling and how we will manage, how health boards will manage their working practices during the transition period. So patients, obviously, cross borders. They don't live, I'm sure Rydian's told us about this many times, they don't live necessarily within a neat health board boundary, and therefore you may have a scan taken in one health board which is needs to be accessible in another, for example. So we have mechanisms to manage that, and we just need to make sure that they're ready, and that things like data migration are sufficiently complete so that others will be able to access that data as we all move. I think the positive bit is all the health boards are moving to the same solution. So, once everybody's moved, then life becomes much more straightforward. It's during the transition phase that it's a bit more complicated.
Fine. Okay. Can't see any other questions for you, Michelle. So if you want to move on to LIMS.
We'll have some more of me on LIMS. Okay. So, and again, we've talked about this before. So 2 big diagnostic programs now running completely side by side. So the laboratory information management system. So this is a replacement for a single solution. We moved to a single system in our laboratories some years ago now, which has already delivered quite a lot of benefit in terms of how we operate across the system. So we are now moving to a new product. This has proved to be quite challenging. I won't go into all the detail, but colleagues will be aware we awarded a contract. We actually took action to terminate that contract and had to change to an alternative solution, which has really compressed the timelines. And I think that's what we're seeing now. So we had hoped that user acceptance testing would be complete. By this point, it is not. It is largely complete, but testing is still taking place across the health boards. We are still identifying some issues in the software. There are still fixes that are being deployed. So that has meant that we haven't been able to maintain the original plan as we had hoped. I think it's not entirely unexpected. This is a completely new product. It's quite different in some respects to the product that we operate currently. And also, we're working with colleagues from all of the labs across Wales, and we're trying to balance the extent of change, so the kind of unique configuration that we want to achieve in Wales against the kind of standard product, and that's a tricky balance sometimes. And I think we're seeing some of that as well. We also know resources are quite constrained in the labs, so the same people who are working in operational roles would also be involved in the testing, and that's a tension. And is a real challenge for the health boards particularly. On a positive note, I think for LIMS, we're doing something a bit different on LIMS, and that is that testing is shared across the system. So not all the health boards are testing every aspect of the solution, it's actually distributed, so that has helped. So we, when the programme board met in May, we put forward an alternative approach to the implementation. which would enable us to complete by the end of December, which was our backstop. And that approach is, rather than implementing on a health board by health board basis, that we would implement on a discipline basis. So LIMS, I'm not an expert, but LIMS they often describe as kind of 5 key businesses operating under one banner, so 5 key areas. So the proposal is, because some of those areas are more ready than others, they've got further through their testing, some of them possibly a bit more straightforward, and some of the bigger areas, then if we could deploy by discipline, then we could actually expedite the overall deployment process. So in effect, a discipline would go live in one health board. We would have a period, it's about 2 weeks. I think he has to make sure that that was bedded in, operating as we would expect, performing, etc. And then it would be deployed quite quickly across all of the other health boards. And then we would move to another discipline. So that plan was put forward. It's been agreed by all of the health boards and trusts. The chief executives were keen to make the final decisions around that, because there's quite a key change, and there are also financial implications. So the feeling was that that was outside of the programme board's remit particularly, and chief execs have been directly involved in some of the discussions around this and the decision making about this. And I think that also reflects the criticality of this system in terms of service delivery. So we have now agreed that we will move forward with that discipline by discipline model. And I anticipate that the first discipline will be ready to go live at the end of September. Slightly exciting, I would say, and certainly from the programs team perspective, is the solution is there. The solution is live. It's sitting there in the data center. It's good to go. And a change was made at the beginning of this week to start data moving from the current LIMS, so that, as we refer to the legacy LIMS, into the new LIMS, so that it will be appropriately populated with data when we're ready to use it. So that's quite an exciting development. I think even now, by the end of the month, I would expect the data, as I say, to appropriately move. It's kind of a trickle feed, so we do that in a careful way so as not to disrupt current operations. All the interfaces are in place and operational, so the solution is good to go. What we'll be doing really for the next month is for those disciplines to be going through their final validation checks and their readiness activity, so that they're ready to shift to the new system. So again, really tight program to the end of December. Really amazing, the whole program team. I'm really impressed every day with the program team, and that's the whole program team. You've got really good involvement from all of our health boards and trusts, as well as a kind of core team, all working really hard. All of the technical folks inside this organisation really working to maintain that timescale. And so working to the end of December, we have got then some activity January through March, which is in blood transfusion. So the blood transfusion labs would be one of the aspects that are supported by this system. So they are particularly complex in terms of their needs and in terms of the level of validation and testing that we would go to because of the criticality of those areas. So we anticipate that we would move the transfusion laboratories onto the new LIMS in that period, January through to end of March. And we've got good support from the legacy supplier, also helpfully is also the new supplier. So we're negotiating some flexibility around that date, but really keen to be able to draw a line, if you like, under the legacy product by the end of March.
Excellent. Thank you for that, Michelle. Any questions on LIMS from Michelle? No, thank you, Michelle. Before moving on, can I just say we've done an excellent job of recovering from a situation where we inherited a program that was in trouble, and this is a turnaround, and the fact that you're still within the original envelope with the delivery window is testament to the hard work that the team are putting in. So please pass on the thanks of this committee to the team for an ongoing job well done.
Thank you, David.
Okay, fine. No more questions for you, Michelle. Thank you. So let's move on to Connecting Care. And for this, we're going to go to Sam Hall.
Thanks, Chair. So Sam Hall, I'm Director for Primary Community and Mental Health Digital Services. So very quick update on Connecting Care. I think we mentioned at the last board that we had to submit a business case to Welsh Government, which we've done for funding for Connecting Care. As of today, we still haven't heard. We haven't had an outcome of that funding request. So what we have had since the last board is commitment to Q1 funding for Connecting Care. And the eagle-eyed of you will notice that we're in Q2. And so we are currently unfunded. We have stretched the money that we have to continue some of the work that's quite critical around Connecting Care, including preparing for hopefully getting the funding to take forward the discovery in the integrated care record, which is an absolute critical part of the Connecting Care programme. So we're continuing to do that work, but we're still very hopeful that the funding will be found. We're in that stage now where people are reaching out to us, obviously from health boards, as the community health product, which is kind of one of the pieces of the puzzle of Connecting Care. Health boards are now starting to get a little bit concerned that the timeline is running very close. So the longer it goes on before we can get out to procurement for a replacement system, the more squash the timeline, the more pressure it puts on us, but more importantly, the more pressure it puts on our practitioners and our clinicians out there in the community who are doing that work. So there's obviously concern around the system. So alongside waiting for the money, we're doing the planning. We're also still running our programme boards. Helen Thomas chairs those programme boards because it's a really complex governance piece on this. We've got local authorities who are replacing their social care system. We've got a mental health system, which is currently being procured by 2 of the health boards. So we're receiving updates from them, and we'll get the next update on that tomorrow at the next board on how those procurements are progressing. And we're also supporting local government in they are managing the kind of rather than necessarily the data migration out of the existing system, but they are moving it into a staging place so they can carry on with their piece of work. To do that, we needed to go through some IG work and get DPIAs from all of the health boards in time for them to do that work. So the Connecting Care team have been helping to chase down that work and support that IG piece, which is can be quite complex. And the other piece of work we're doing that is to understand some of the requirements around that community health piece are also linked quite closely to other deliveries which are wider in the health system. So things around cluster working. So being able to deliver that kind of multidisciplinary team support out in primary care. They use a lot of similar methods and systems that would be required in the community health space. So to really understand that, we are hosting a workshop in DHW to bring together all of those interested parties, the people that understand how this stuff needs to knit together, to see whether there are some economies of scale here in doing something once that will support that work in the cluster area and in community health as well. So that's being hosted at the end of this month. So we'll be able to feedback on that. But it's going to be a running theme through my next 2 pieces of work, that we don't have money currently to take this forward.
Yes, I'm afraid this has come up before, Sam, so it's an ongoing issue. Ruth?
Thanks, Sam. I mean, obviously, this is such a critical piece of work to so many across the system. My question is around the funding. Even if funding was confirmed this afternoon, are we not now so far through Q2 that actually we don't stand a chance of catching up on those milestones anyway, because we have to resource the program in order to deliver that? It's not quite clear to me why we're not red on that basis as opposed to amber currently, because even if a big Santa bag of cash appeared, there's still a significant amount of work to do to ramp our resources up again in order to start to get back to where we were in terms of delivery of some of those milestones.
Yeah, no, it's a good question. So we have kept some of the staff that we would need to be able to ramp up quickly. We've also done a lot of the groundwork, so the requirements gathering, and we've put a lot of the procurement work ready. So should we get the bag of money to go out to procurement, we are ready to do that very quickly. It will be a much more constrained timeline, absolutely, because procurement takes a long time. So these are the things that will put the pressure. Team wise, we're also sharing people across my directorate now. So rather than lose necessarily everyone out of Connecting Care, we're using them in other programs and other projects of work, and we will pull them back in as and when we need them. But there will be some, we will need some extra people. Hopefully we can get those people in quite quickly. But as long as we hear literally in the next month at the latest, then we're still okay. I think if it goes any longer than that, we would start to be able to say we're going to very, very much struggle to bring this in. And whilst we might feel that that's a pressure in DHW, it is much more of a pressure for health boards who will have a system. And that's the real criticality for us. We will stretch. That's what we do in DHW. We will support as well as we can. But it's the pressure that's being put on the health boards, who are now, very concerned that their system will disappear and will leave people without something.
Yeah. Okay, Rowan.
So Sam, that last comment really goes to the heart of risk and impact of risk. So at one level, we possibly are, trying not to look like the awkward squad, but you can't crochet or knit one of these systems. There's money has to change hands at some point. You said that the health boards have concerns. Can you talk a little bit about how those concerns are? Because health boards have a lot of concerns at the moment. So how those concerns are communicated to boards within health boards or management teams, and how we can speak with one voice on the consequence of this. Because again, we're reporting on risk, but we don't own necessarily all of the consequences of it. So
no, we don't. And yeah, sure. So no, we don't. They will be their risks and their corporate risks and their corporate risk registers to be dealt with by their boards. But we also know that they're also putting pressure and asking the questions of Welsh Government as well. So we do hear that. We do know that they're actually they may not be coming together as one voice, and that's because there is a slightly more stretched out tail on community health. So the way the contracts run, some of them have got longer. They have less panic. It's not such a cliff edge for them. They've got it a little bit further away. But there are some where it's feeling very close. And so they're obviously putting pressure, raising that as a risk. We speak to them all the time. They are represented on the programme board, and we are very strongly making those messages felt back in Welsh Government. And I must say the conversations in Welsh Government, they are hugely supportive of this. The policy lead, Alex, we've had conversations where he's told me, just how many minister meetings he's had where he's raised, how important this is. So our understanding is the request for funding has gone up in ministerial advice literally in the last day or so. So, we have been working with Claire's team and the health boards to make sure that the sum that we're asking for, isn't overblown, but it'll get the job done that we need in the next year. We've cut our cloth as much as we can, as of the health boards, frankly. And so the sum that we're asking for now is the best we could possibly get and the best we could possibly ask for in this year. And it's with the minister. And before I go on to GP migrations, the funding for that is wrapped up in that request that's currently with the minister. And I think a number of other things are in that request too.
Okay, fine. I'll hope for the best on that one, Sam. No other questions on that. So do you want to move us on to GP systems framework, please?
Yeah, of course. And so, I mean, I can start with a hooray, actually, on this one. So we found out late on Monday that the sale had been done. So IMPS, which was the system that's gone into administration, has now been bought by a new supplier. That supplier is One Advanced. So for those of you that know health very well, as you probably all do, they are a large supplier of health systems, not just in Wales, but you know, worldwide, frankly. So they're a well-known name. So so now we have effectively a new owner for the system. That doesn't change where we are very much. There were some negotiations as part of the sale where you know, we needed to go back through some of the things like, you know, the service charges and some of the costs for the current system. All that negotiation happened. We had our documents over with them to review. They're happy with what we've asked for. We're happy with what they can provide. And so we're still in that stable situation that we always said was a primary, you know, the primary position we wanted to be in, which was to maintain the service. So that's where we are. As of today, actually as of the end of July, which was only a few days ago, we had 84 migrations complete. With 109 remaining. We've had very, very good feedback from the practices that it's going. I really don't like saying smoothly, just in case, but actually it's going really well, and the feedback has been excellent from the teams. And so that's running at the current rate of 2 a week. As you know, the part of the negotiation with the incoming buyer was that we would accelerate that to 4 a week. That starts in the autumn, and that is so that we can be completely off the IMPS system by May of next year. There are loads of reasons for that, and as we found out in the first part of this meeting today, around EPS is a critical element for that. We can't switch on EPS in practices until they have migrated to EMIS. So what we'll need to do, and again we touched on it this morning, is we're going to have to slow down a little bit on EPS to speed up, which obviously won't make you happy, Rowan, but we will. So we're going to slow down, put our resources into getting everyone into EMIS, so they're in a position to then consume EPS, and then from next May we will accelerate the EPS rollout, bringing that in, looking to bring that in by November 2026, which means it'll be brought in from July 27. So whilst it'll slow down for a little bit, it will then accelerate because we'll have everything we need to be able to do that. Again, that is dependent on some money coming from Welsh Government. Again, it's in that piece that I said that's gone up to the Minister. But we are working with finance as well to find anything we can in the system to keep moving at the pace we need to move. And I just, you know, like to take the opportunity to thank the combined. I mean, it has been an absolutely multidisciplinary cross DHCW ask to get this in. Michelle has been critical to that piece of work. When we've had people from Sam's team, from finance, you know, loads of people being involved in this to get us to the state where we can now hopefully start to motor with this migration work. So I think the only other thing to highlight on this is that where we will now accelerate and where we're just starting to work with are those practices who didn't choose to migrate. So as you know, there was a piece of work was undertaken, and some practices chose to move to EMIS from IMPS. There were around, I think it's 88 practices chose not to move. That opportunity is obviously, you know, that there isn't an opportunity to stay any longer. and so they have to move. And we refer to these as forced migrations. That's the term we're using, and we're just now starting to speak with those practices to talk to them about what that means for them, because they may not have been as prepared for this as the practices who are expecting to move. So it's going to be a harder piece of work for them. So my team are, out there every day, every week with practices, supporting them and holding hands. So we will continue to do that, and to be very, very cognizant of the fact that the people we're talking to now are in a very different position than the ones who are keen to go.
Yeah. Okay. Thanks, Sam. Anybody got any questions for Sam on that? The only question I've got, Sam, is there a window on the funding decision that is needed? How long have we got before it becomes a barrier to doing anything?
So at the moment, we're working, as I said, with Claire in finance to see if there are other pockets of money that we can use to continue to do this. So I don't think there's not a cliff edge of cut off where we'll run out, but it could be to the position where we overspend and then try to recoup. At the moment, we've got some vacancies in areas, and we'll be using some of that to support this. I must stress, we don't ask for money unless we need it. And we've been very, very really rigid about that, actually. That we and Welsh Government have been quite forensic with us over, have you looked down the back of this sofa first before you come to us, and we are absolutely doing that. So I don't think there is a drop dead we'd have to stop.
No, okay.
But what it might mean is that we would have to slow down again. That slowdown would have a knock-on effect, and potentially, because of the agreement that we have with the buyer, which takes us up to the end of May, should we need to extend that, then that would again potentially cause us some consideration that we would need to take into account with a new buyer, which we wouldn't want to do.
We could spend more money because of the delay in providing the funding and in a timely manner, basically.
Yeah, absolutely.
Okay, Rowan.
Just to say, Sam, it's not your job to make me happy. That's my husband's, and we don't report that particular project here, so that's probably better for everyone. Saves all our blushes. The comment, I think, as we have this recurring issue around funding uncertainty across projects, is a question to the committee, really. Are we capturing the consequence of those uncertainties across programs? So, we're seriously, to Sam's point around, we need to change GP practices onto EMIS in order to unlock, the electronic prescribing, and the consequence for that in the system. At some point, things can happen more slowly, but there is a cost consequence, and there's also a consequence to clinicians and patients. So it's maybe not for now, but I think it's something we should think about.
Yeah, that's a good point, Rowan. Okay, I can't see any more questions. Thanks for that update, Sam. Can you just close out with the remaining item for you, which is the National Eye Care Programme?
I can. And I can start by saying we will close this programme. So it's a good opening. So basically, we now have, in June, we had a letter from Welsh Government really clarifying the position and the activity they want us to undertake with regards to eye care. And that is for us to focus on electronic referrals. So referrals in the system, particularly from primary care, and to look for a system that would allow us to do that. So they've asked us to focus on that, and they've given us a very challenging timeline to do that. So much so that we're already out with an invitation to tender. We went out at the end of July to do that. So we will officially close the digital iCare program as we know it, and this will get taken forward as just as a project. It's one single procurement of a single system that everyone across Wales will be rolled out onto quite quickly. Welsh Government are referring to it as a tactical solution, as there will need to be a longer term system bought, but for now that's been the ask of Welsh Government of us, and we'll stick in to do that. And just while we're on the topic, the DHW hasn't got any funding to do this either, so we are again we are absorbing that into the primary care team. With also some support from Sam Lloyd's team on the technical elements of that as well. It isn't a huge, it's not a huge amount of money for DHW to do this. It's just, I think it just shows, firstly, that you never know what's coming in healthcare, and there was always another ask. But secondly, also the flexibility in the way that DHW is trying to restructure to allow us to do that and to be more able to respond. And I think that's a real testament to, how we're transforming how we work to be able to do that. And so whilst we will bring the closure report to the programme delivery committee, we probably won't be reporting on the single project.
Okay. Thanks, Sam. And just for clarity, I think what you've said is previously at the board meeting last week was Welsh Government are providing funding for the IT system we're out to buy, and we're basically having to cover the cost of the implementation within the team as you've just described. Is that correct?
That's right, yes.
Yeah. Okay, thanks. Marianne?
Thank you, Chair. Just for clarity then, Sam, you describe this as a tactical solution, and there will be need for the long option. Are we likely then to see double spend being incurred here down the line?
I mean, that's a really good question. So, I mean, we've gone out for an open competition, obviously, for a solution, but it is to take us up until, top of my head, it's 2027. So there's a date in I think it might be something like March 27. So with that will obviously come the health boards, particularly, have a lot on their plate, and thinking that they're going to have a system coming now and then potentially a new one in 18 months, 2 years time is probably not going to be that palatable. However, Welsh Government are really concerned about how e-referrals happen between primary and secondary care, and being able to move those waiting lists along and do more in primary care than is currently happens. So you can see they're in a very difficult position. So would there be double spend? Well, we'll get the tactical solution. We don't have a lot of money. There's not a big spend envelope on this. So, and it's a subset of all of the requirements you would want in a final solution to go forward. So I suspect there may be some, but I would say that that's going to be a minimum, because actually we are only going to procure what we really need for the next 18 months.
Thank you, Sam.
Okay. Thanks. Thank you for those updates, Sam. We'll move now on to the Microsoft 365 Enterprise Agreement and go to Sam Lloyd.
Thank you, David. This is the first time we've spoken about this in this committee, so I'll just give a bit of an overview of the project and what it is that we're looking to achieve. So the Enterprise Agreement is a licensing agreement for large organisations to procure Microsoft software and services. There is an existing All Wales agreement for which DHCW is the named authority, and we enter into the Enterprise Agreement on behalf of NHS Wales. It's obviously for the provision of critical collaboration tools that the whole system relies on daily. So, meetings like this and other associated activities, the Microsoft suite really does underpin the day-to-day running of the system currently. So it's a really important procurement and vital that we get it right. The Enterprise Agreement only establishes a pricing arrangement with Microsoft. The actual license acquisitions are processed through the separate sole supplier framework agreement, which we put in place previously. So this is just about fixing pricing effectively. What the enterprise agreement will consist of is a price book, so that's agreed annual pricing and discounts for the duration of the agreement. So we'll see what normally happens is that there's a sort of sliding scale of discounts, so the discount level reduces over the duration of the contract. There might be minimum purchase commitments, so we'll be expected or required to buy a particular quantity of a particular type of license. And then sometimes we get some concessions as well. So there might be deviation from standard licensing terms. So we might be allowed to continue to use older versions of particular products if that's something that we need to do. The current agreement that we've got commenced in July 2022, and that was for a period of 3 years with an option to extend for a further 2 years on a +1/+1 basis. And we made a decision in January of this year to invoke the first of those 1-year extensions. And the renewal is included as part of the remit letter under priority 5 core national infrastructure. So it's something that DHCW is accountable to Welsh Government to deliver. As I mentioned, we do have a further +1 extension should we wish to invoke it, but we're choosing to negotiate a renewal now because obviously having that additional extension in our back pocket gives us a fallback position if we need it. If we waited another year, we don't have that. So we think it's quite important to try and settle this now. The enterprise agreement includes the core licenses, so what are known as E3 or F3 or E5 licenses, which is basically the suite of products that people use, and there are some variations in that. Plus there's Power Apps, there's Power BI, there's Project and Visio, and there's Copilot, which obviously we're seeing increasing demand for. And the true-up cost of the previous year was 32.5 million, so that's a rough idea of the sort of annual cost under the current arrangement. But we do see, as a result of those declining discount levels, we do see roughly a 5% year-on-year increase over the duration of the contract. The default position, if we just use the sort of national pricing structure without a new enterprise agreement, or if we don't manage to negotiate a successful enterprise agreement, then our costs will look to increase significantly. And just doing a like-for-like comparison based on what's called the SPA pricing, we'd be looking to increase costs by about 50%. So that's a huge increase on a £30 million contract. So it's really important that we go through the due diligence to get this right. So the approach that we're taking, well, firstly, the outcomes that we're looking to achieve are an optimal license model. So we need to make sure that we're only buying licenses that people need and that we've got the right balance of different licenses across the different persona types. Obviously, we're not therefore buying licenses that we don't need, but people do have access to novel functionality that they might require, such as Copilot, where that's appropriate. We obviously need to have the best achievable pricing, so we want to try and get further discounts beyond the standard SPA 24 pricing. And we want to look for the best achievable value-added benefits, such as adoption support, concessions, any social value support that Microsoft can give us. And the way that we're looking to achieve those is through the establishment of a formal project. So we've got a project board now up and running, which has got cross-organisation and cross-discipline representation. So we've got digital, clinical, workforce, finance, and commercial colleagues all represented on that project board, because obviously this is not just a digital procurement. It's really important that we have those other disciplines represented, and many of the benefits will be realised through workforce opportunities and so on. So we are bringing in some external support to assist with requirements gathering, and there's quite a lot of work that's going on at the moment, working with health boards to pull together or to identify the personas and then to pull together the license, the software licensing that will align with those personas to make sure that we're buying what we need. And that's really taking place in 2 phases. So there's current state analysis, which is gathering user profiles and requirements for new products. And then there's a second phase, which is optimizing those licenses, undertaking further commercial analysis and contract development, and then the actual negotiations with Microsoft. And then finally, the timescales. We have essentially we need to have we need to have a close understanding of final costs by December so that we can align with organizational governance processes. It's one of the most complicated aspects of this is going to be orchestrating governance approvals across all of the different bodies who are involved, because each organisation will need to secure funding approval through their own boards and their own internal governance processes, and then obviously we need to bring it to the HCW board for approval as well. So that's going to be complicated. So we need to have costs understood by the end of the calendar year, and that gives us that run in then and the opportunity to have the new EA in place from the 1st of July in 2026. So we've got about a year, but actually there's a huge amount to be done in that time. So yeah, we are up against it time-wise.
Okay, thank you, Sam. Any questions for Sam? No, Sam, from what you said, we are on track, but it's all a bit tight. Is that a fair summary?
Yes, it is, David. Yeah, we're well underway now. As I say, we've got the partners working with us, helping us to pull those requirements together. That work is progressing well. I think it is just the governance timelines really, which are the major risk.
Okay, cool. Okay, thank you for that, Sam. I can't see any questions on that. So can we move to the cloud transition, please?
Yeah, thank you, David. So this is the program to migrate significant proportions of our estate from our on-premise data centers into commercial cloud. We are currently in a program mobilization phase, which means that we are obviously setting up program structures, establishing milestones and delivery targets, bringing in resources as required, pulling together procurement strategies, framing up tenders and timelines, and so on. So we have now engaged with Welsh Government to confirm the success criteria for the current financial year. One of the conditions of the business case approval was that we had an 18-month kind of milestone or gateway process whereby progress would be agreed in order to potentially unlock further tranches of funding. So we've agreed what those success criteria are. We are working with some existing suppliers to undertake design work and landing zone configuration. So we've been able to bring some of that work forward using existing commercial relationships. We've drafted a migration wave approach. So we've got wave candidates we've got migration candidates for wave 1. So we think which will be the first set of services that we look to move into the cloud. We're shaping up the training approach as well. There's quite a major focus on training and staff development through this program, and there's budget that we set aside via the business case to do that. So we're looking at skills gaps and training needs analysis at the moment so that we can make sure we factor in organizational development and skills development alongside the technical transition work. So the next phases of work will be to continue to recruit roles to support mobilization. So we're particularly looking to bring in some architecture roles to support some of that sort of design and development work. Shaping up the procurement approach. So we think, well, we will be splitting the procurement into 3 lots. So the first lot is the establishment of design activities and landing zone build. The second lot will be the actual migration of systems and services from on-prem to the cloud, and the third lot will be the sort of governance and organizational transformation aspects, which will include staff training and so on. So we're hoping to have tenders issued for those elements by the end of August, and I think those are the main points. So we're progressing well, still very early stages, but we're on target for where we need to be now. Thank you. You're on mute, David.
Yep, sorry. Great to hear that the program's now up and running. Thanks for all the hard work in getting us to this point, Sam. Anybody got any questions? No? Okay, we'll look forward to further updates on this as you move forward, Sam. Thanks for that. Okay, so at this point, we're going to move on to item 5.2, which is the corporate risk register. And Laura, who's standing in for Chris, is going to cover this for us.
Thanks, David. Yeah, so this is our normal risk register report that we provide to the committee. So in terms of the corporate risk register, there's currently 21 risks on this, and 7 of which are assigned to this committee. I don't propose to go through all 7 of them, Chair, if that's okay. So I just wanted to highlight that there are 3 new ones that have been assigned to this committee since the last meeting. So The first one is DHCW 0347, and that's the National Target Architecture Transition Roadmap, and then DHCW 0348, which is the transition to the new data architecture. So I was just going to hand over to Ivan to briefly update us on those two risks, David, before moving on, if that's okay.
That's absolutely fine, thank you.
Fab, thanks, Ivan.
Diolch, Laura. So I think the key thing from the risk on national target architecture is the word agreed. If there is not an agreed national target architecture, then what happens is that we need to negotiate each time for each new item, and there are a variety of different views that need to be resolved and or brokered throughout the life of the program in certain cases. So it's not about completing the target architecture project specifically, it's more about reaching an agreed position and or a directed position by Welsh Government, which gives us a solid framework that we can rely upon to make the strategic investment decisions and prioritizations that we need. That said, the actions are strongly driven by the activity of the National Target Architecture Project Board. I'll just mention an escalation from that project board. So the project board obviously is doing a current state assessment, a target state co-design, and then a transition roadmap design, but it does not in itself have the mechanism through which it can impose that position as that outcome as an agreed direction across the NHS in Wales. We're working on the assumption that there will be a new architecture and standards board established under the DDAT leadership group, the new governance inside Welsh Government at the national level, and that architecture board will then be able to endorse recommendations from the project board. It isn't there yet, so we're working on an interim basis of using the project board itself, on which all health boards and Welsh Government are represented, and also an architecture community of practice to, if you like, make interim collective consensual decisions. But I just want to emphasize that that is what we do in programs, and it's necessary, but it's not sufficient. So we are working closely with government to get the national level governance, which will be more directive with clear authority in place, because that will really help us all over the next several years of planning activity. And I'll just cover the next one, the transition to the data architecture, then back to Ruth's question, if that's okay. And then on the data architecture, this is a slightly different one. This is about the speed at which data does transition from our existing infrastructure, existing data infrastructure, into the NDR and the CDR particularly. There are some constraints there, particularly the discussion that's been going on over the recent months around the WASPI Joint Data Controllership Agreement. That also comes up in the escalation report, which Laura will give next. So I've given a quick update on where we are with that, and I'll just mention it later in the escalation phrase. But we're trying to move together with partners to get a firm roadmap in place so that we can get more confidence about the speed at which the data transition or the data migration will go.
Okay. Ruth, you got a question?
Yeah, thanks, Ivan. It was just a question about governance that we assume will be put in place at a national level. Are we assuming that because it is on the agenda and has been accepted on the work plan for the DDAT governance group for their next meeting for their consideration, or we assume that because it's just something that we would like?
Well, no, I would say we're assuming it because in November we made recommendations to the Welsh Government on architecture and standards. Those recommendations were accepted in our IQPD or endorsed in our IQPD by Mike Emery. We've also presented them to the Minister in February and in March. She's noted them, although not formally directed them.